Hello. 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 आप बोलो। हेलो जनरेटेड है, मैं उसको चेक कर लूँ। हेलो
तो मुझे भेज दीजिए आप, किसको भेजा आपने?
आपको भेज रहा हूँ।
One of the first and big corporate in that city. Landmark achievement.
कहाँ से लगा? एक काटी टेप मार लो। ये हिल रहा है कहीं से?
Hello, I'm not sure.
एक टेप ही मरा दी, नहीं तो सब हिल जाएगा इसमें।
Good morning, my dear delegates and respective teachers. A very warm welcome, all of you, to the Kgmu Lucknow. So this is first in kind workshop from CME in Uttar Pradesh, and I'm very happy to have all my mentors, teachers, and senior faculties here as speakers. So to begin with, may I request Dr. Anil Gowal sir and Dr. Josna ma'am to chair our first session.
This topic is cannulation strategies of Vinit versus Ecmo.
I would like to invite sir for taking the lecture on clinical strategies. I will briefly introduce about him. He is a very dynamic and senior cardiac surgeon, and due to his profession, he dies out for the patient and number of experience in every techniques. So it's our honor to have sir to take the initial lecture on how to cannulate the patient.
Changing into this. A very good morning to everyone, and thank you very much for inviting me to speak on this topic. And my topic was planned to be the second topic of the day, but due to some delays and taking this topic as as a first speaker. Thank you, Dr. Karan and Team Igmo at KGMC and all the organizers for calling me. Best regards to Professor Anil sir and Professor Jyotsna ma'am. So without much a delay, as we are already lagging time, I will start my topic. And the topic given to me was to talk on cannulation strategies for VV and VA Ecmo. Myself, Dr. Vijayan, then I'm senior consultant at Apollo, an ex-faculty from KGMC and pass out CTVS from KGMC itself. So wonderful to be delivering lecture on this. So I'll, as this is a very, very vast topic, what I'll do is I'll try to cover in short what we have to keep in mind. And, the whole idea behind this is to let you know what are the various things that are available and where are the various strategies that are there, so that when time comes and when the patient needs, we can go for this. So, as we all know that the extracorporeal membrane oxygenation, ECMO is included in a broader heading of ECLS, that's extracorporeal life support. And the first ECMO was in an adult was described in 1972. So we see that ECMO augments native circulation and or gas exchange to temporarily support patient experiencing cardiac or respiratory or both the failures. So, Ecmo circuit is a closed system with venous drainage cannula, centrifugal pump, control console, oxygenator, air oxygen blender, heater, cooler, and return cannulas. So, the condition where the patient is suffering, actually, that is what determines what type of cannulation and what type of strategy has to be used. Both the VV and VECMO have their own indications, their own disadvantages, limitations, and considerations that we have to take in consideration while using this. ECMO, due to the COVID pandemic and especially the VV ECMO, has been used quite a lot during the recent times in centers across India, and so that has made the impact more important in today's scenario. So I'll be basically dwelling upon what's the cannula, how to select a cannula, general considerations for cannulation for ECMO. That's how we have to go ahead with the cannulation. And this mainly requires the cannulation studies are mainly for the peripheral ECMO that are more commonly used, and I'm going to give you more on this. Then we ECMOs, the VA ECMO that encompasses VA ECMO, VV ECMO, venous, arterial venous ECMOs, and BiVATs. Then the veno-venous ECMO, that is mainly for the respiratory failure. Then we have a femoral vein, IJV, VV ECMO. Then femoral vein and ECMO and dual lumen cannula, that is the avalanche cannulas. And then obviously the central cannulation and peripheral cannulation, that is done for the VA ECMOs. So we see that the different modes of ECMO support require different types of cannula. These also require different connectors and securing techniques. The main goal of ECMO cannulation is to provide the least traumatic and most durable simplified method of delivering the blood to and from the circuit. The main determinants for a VA ECMO are anatomical considerations and a targeted flow rate. Generally, the cannulas are chosen to support a flow equivalent to cardiac index of 2.2 to 2.5 liters per meter square per minute, and which is considered a full flow in an adult. Arterial cannulas typically used are 15 to 25 French. These will encompass both the central as well as the peripheral cannulas, and the venous cannulas are usually 19 to 25 French. The intent of appropriate cannula choices is to provide a full flow, and in addition to small diameter, king, side hole occlusion, reduced number of side holes, and increased cannula length, we know that all these increases the impedance. In contrast to venous cannulas, the arterial cannulas tend to be smaller but shorter to provide less resistance to the flows. A cannulation cart with all anticipated equipment, including cannulas, wire, drapes, and gloves, are very helpful in emergency conditions. So we see that a broad set of cannulas, as they are very important before going in for cannulation for anyone. Apart from that, a variety of guide wires ranging from extra stiff guide wires that are provided by the Emplaza Super Stiff Boston and to the smooth PTFE guide wires. These are Kgmu guide wires. They are used and should be available for all the procedures that we are planning. Ultrasound examination of the planned vascular access definitely helps us. Similarly, echocardiography is very useful in facilitating correct placement of venous cannula into the inferior vena cava or right atrium to optimize the drainage. These are very, very important when we are going for a femoral peripheral cannulation. Cannulation under local anesthesia is possible for a patient who is spontaneous breathing and alert, but generally a patient requires sedation, and better to go for all these when the patient is intubated. Requirement for force during cannulation may be a sign of evolving complications. So very important over here is that there should be the minimal force when we are using this. An obstruction at the time of placing a cannula gives you resistance, and very important not to damage, and we might end up having a retroperitoneal bleed. For a target flow rate of 3.5 to 4 liters per minute in adults, a peripheral arterial cannula of 15 to 17 French is sufficient in most of the patients. In the presence of peripheral occlusive disease, we go in for a much smaller diameter cannula so that we can give enough blood. Recommended to implement a distal limb perfusion with a 7.5 to 9 French vascular reinforcement sheet. Now these are commercially available, can be connected, and definitely with a process we can perfuse the distal limb when we have put a femoral arterial cannula. So this prevents ischemia of the distal limb because Ecmo is supposed to be there for a long time. So this definitely helps the limb to be viable and lactates not to rise. Recommended to implement distal limb perfusion, and then in order to monitor distal leg perfusion, the NIRS, that is the near infrared spectroscopy, is very useful. It is important to obtain baseline values of both legs prior to cannulation to be able to validate leg ischemia. And for peripheral venous cannulation, a 25 to 23 French cannula, 35 to 55 centimeter long is sufficient in adults. Most of the times you try to put in a 23 French cannula so that we are able to have a good drainage. Coming to the technical aspects, team timeout is recommended so that we have all the team and the equipment available before going in for a cannulation. The patient might crash anytime. 2 units of blood should be in hand. Patient must be positioned appropriately. Now these mostly are for the peripheral VA Ecmo. So a supine or a Trendelenburg position in case of neck cannulation. Standard preparation under sterile condition must be carried out. A portable ultrasound is handy for relevant vascular anatomy. A surgical technique we all are very familiar with is very useful and has to be used for all the patients when we are going in. Use a guide wire. So this prevents adherent migration of cannulas in adherent injury. And we can have a fair access and a knowledge if there is any occlusive disease anywhere in the line. In the event of venous cannulation and availability of echocardiography, position of the guide wire in the right atrium should be confirmed by pulling and pushing the wire to increase visibility. X-ray imaging can also be used to visualize the cannulation procedure. In case of Kgmu, these are the soft guide wires, and a stiffer guide wire are needed. Fluoroscopy is recommended to avoid vascular injuries. So sometimes fluoroscopy is also very useful when we are using these guide wires. A small incision is usually not necessary, however, may be useful in some patients, particularly males. Dilator should be advanced while pulling the guide wire slightly to keep a wire on tension. It is important to be gentle and not to use force while advancing the dilators. After every dilator change, the guide wire should be replaced. When a dilator is exchanged, it is crucial to manually compress so that we have least amount of blood loss. A heparin bolus, we are normally using 100 units per kg, and it is given once we are in there. All necessary dilators from the cannula kit should be used up to the appropriate side. One should not overdilate to avoid bleeding at the puncture side. Obviously, cannula leak is a problem that we should try to avoid all these things. Then one needs to ensure that an introducer is beyond the cannula tip by at least a few centimeters. When advancing the cannula, it is extremely important to advance the introducer with the cannula as a single unit. When a venous cannula is in the right atrium, as demonstrated by echocardiography, a TE helps this very nicely. The introducer and guide wire are simultaneously removed. Backflow is confirmed, and then the venous cannula is clamped. It is important to minimize blood loss during this process. The arterial cannula follows the same principle. We try to avoid blood loss. The arterial cannulas are smaller in size. Mostly we are positioning them in the common iliac veins, arteries. It is important to ensure that the tubing is free of air bubbles, particularly at the junctions of the connectors, and to connect the cannulas to the Ecmo tubing. Flushing cannulas before connection to the Ecmo circuit to wash out possible thrombus formation is strongly recommended. One should commence therapy gently. We normally start on a low flows and then gradually increase the flows of 3 to 4.5 liters per minute. That is a preferred flow rate for any adult. Then centers promote a higher flow rate, strategic flow higher than 4.5 liters, which has associated risk of left ventricular distension secondary to after load increase. I'll dwell a bit on this in my further slides. Post-cannulation and imaging is very, very necessary, and echocardiography as well as an X-ray is definitely a required. So we are sure where the cannulas are placed. So now was a brief about basic technical aspects that we have to take in consideration while going in through a peripheral Ecmo. Now coming specific to the two types of Ecmo that we are using, these are the VA Ecmos, there's a veno-arterial Ecmos, and then the second type is the VV Ecmo. So the veno-arterial Ecmos can be divided into a central VA Ecmo as well as a peripheral VA Ecmo. So central VA Ecmo involves sternotomy, direct surgical cannulation of the right atrium and aorta. Institution of central Ecmo occurs in theater and requires a full surgical team. The advantages are this, that we have a very good venous drainage and a reliable arterial return to the proximal aorta in antegrade fashion. It allows full control over left ventricular decompression by placing a vent. We can place a vent in the RSPV, and the LV apex can be used in some of the patients, although these are not desirable, because sometimes what happens is that these patients are going to have a LVAD, implantable LVAD, and then this site might not be used later on. The size of the cannula is defined by the body surface area. A perfusionist can do that all the time, and the calculated Ecmo flow necessary to achieve metabolic requirements of the patient. Usually 20 to 24 French aortic cannulas and a venous cannula in form of two-stage cannulas ranging from 30 to 34 to 40 to 46 French are adequate enough to drain blood for all these patients. It allows full control over left ventricular decompression by placing a vent, usually via RSPV, and we can use this. It is of utmost important to secure these cannulas in position to prevent any bleeding from the cannulation site. Whereas when the sternotomy has been done or thoracotomy has been posting snuggers, spigots, fixing the cannula to the chest wall and within the chest cavity, then again fixing these cannulas to the skin does help to secure the cannula in this position, and there are no accidents that we encounter in these patients. So this schematic diagram shows a central Ecmo, whereas the blood is drained via a large venous cannula from the right atrium under negative pressure and transferred to the oxygenator. So we see this blood is being drained through here, and then the cannula can be tunneled under the skin and chest, closed if longer than few days support is anticipated. So we see this that over here it's a very central VA Ecmo, and the patient is being drained out and through a pump and then going to the oxygenator and then getting returned through the aortic line. A central Ecmo can be used as a first choice modality for cardiorespiratory support. Now, most of the times the cardiac surgeons, infants as well as adults has poor cardiotomy shock, and can also be used an upgrade from peripheral configuration when it does not allow to achieve adequate flows. So when we are not able to achieve adequate flows, we have to use this and to provide a good end organ function and overcome problems inherent to peripheral Ecmo. The few noted problems are the LV distension and differential hypoxia. That is a north-south syndrome, and I'll just discuss about that in a short time. The major advantages are that there is a highest flow rate suitable even for patients needing supraphysiological flows. Sometimes required in patients in sepsis also, supports both oxygenation and circulation, can be done and is administratable for post-cardiotomy, cardiorespiratory failure, and it perfuses all parts of the body and drains well all parts of the body. The main advantage is that there's a sternotomy-related issues, there's bleeding, infection, re-sternotomy. Sometimes the cannula moves or the cannulation is not proper, aortic dissection, inability to mobilize the patient if the chest wall is left open, and then ischemic events of embolic origin are potential complications of this technique. The other form of VA Ecmo is the peripheral VA Ecmo. In this, the blood is drained from the IVC via femoral cannulation, and it passes through a centrifugal pump and oxygenator and is returned to the patient via the femoral artery. Mostly we are using two sites so that the declamping is easy when we are weaning off the patient. And we see that a reperfusion line that I discussed previously is also used to ensure a distal limb perfusion, very important when we are using a peripheral VA Ecmo. Oxygen bladder is returned to the arterial part of the systemic circulation using peripheral cannulation. The various modes that can be used, and the most commonly used is the femoral artery. But then if there is a peripheral vascular disease, then the other areas that can be used, it definitely requires surgical intervention, has to be opened up, an axillary or a carotid in infants and children can be used. Is a common carotid that is being used. And these are used by placing a graft over them, mostly 8 millimeter to 10 millimeter, and then connecting them, securing them to a cannula. This configuration of circuit bypasses the lungs and the heart. And in peripheral cannulation, it can be performed using a percutaneous Seldinger technique, as discussed, and or open cut down with end-to-end side graft background to the artery. The venous drainage is provided by the cannula in the femoral or the internal jugular vein. So we see this, that the most common artery used for peripheral VA ECMO is a femoral artery. The arterial return is directed into the descending aorta, while arterial cannula placed in common iliac artery. It is preferable to place the venous and the arterial cannula on two different sides so that the decannulation and there are no complications. The femoral venous cannula is inserted into the right atrium to provide excellent drainage of the venous blood. Sometimes we still are not able to get the return, desired return, and then we have to go in for a IJV placement of cannula as a second cannula. The rationale for using of the right side, we try to use the right side femoral venous sites, is related to the relatively vertical course of the right femoral and common iliac veins into the right-sided inferior vena cava. The left common iliac vein, on the other hand, crosses the vertebral column and aorta to reach the inferior vena cava, resulting in greater risk from left-sided venous cannulation. So the preferred site for a venous cannulation is mostly the right side, whereas cannulation of the arterial can be from the left side of the patient. A lot of centers will use both the right side for cannulation because easy access for cannulation to the patient and for the surgeon and an intensivist over there. So in this diagram, you can see how Dacron graft has been used over here. So this is the return cannula. It has been drained by a femoral vein, but again, because the femoral artery would not have been found to be good, catheter graft has been used, and then this graft has been connected to a arterial cannula to give the inflow to the patient. Coming to the problems in peripheral VA ECMO, we see that there is distal limb hypoperfusion. We see this in most of the patients, and reason is the femoral artery lumen is particularly occluded by the cannula. So large cannula, we have used this, and we find that most of the times it is very snugly fitting and may be very difficult sometimes to put in a cannula, especially in the Indian subset where the body surface area is less. And at the same time, then there is a retrograde flow that redirects the little remaining native femoral blood in a retrograde direction. So both these combine together and can lead to a distal limb ischemia. What we do is we put we have multiple cannulas now that we can connect over here, and we see in the diagram that we can connect, and that provide a distal circulation to the limb. Then one of the most common problems and a thing that has to be kept in mind is the Harlequin or the north-south syndrome. We see that the heart is ejecting all this time. We want the heart to eject. Even when we have put the patient on a VA ECMO, we want the heart to eject. This is very important so that there is no thrombus in the aorta, and we are able to keep the heart ejecting. So under these circumstances, what happens is there is a retrograde flow that is competing with the native circulation generated by the heart. So in the patients in whom the lungs are very poor and they are hardly oxygenating, we see this can lead to a situation when the upper and the lower parts of the body, they receive blood supply from different sources. So whereas the lower end of the body will receive supply from the cannula that we have placed, that is getting you an oxygenated blood, the upper part of the body is going to receive blood mainly from the heart that is ejecting, and with poor lung function, they will be mostly getting a deoxygenated blood. So this becomes clinically relevant when lungs are severely incompetent and LV receives unoxygenated blood. The resultant arterial hypoxemia in upper part of the body, and there is cyanotic upper appearance of it. This watershed phenomena during veno-arterial Ecmo visualized by computed tomography. In this diagram we can see, whereas this is the heart and this is the ascending aorta and this is the arch and the descending aorta. We see this over arrow over here, that this is the area that is getting a good blood and an oxygenated blood, whereas the low contrast blood coming out from the heart is supplying the upper part of the body. So this is a differential hypoxemia that occurs and a watershed phenomena. Now what we can do is we can adjust the ventilatory setting, FiO2, the PEEP has to be raised, and a recruitment maneuvers to see that this is less and less. Optimizing lung function, that is diuretics, draining effusions, and so on. Upgrading the circuit to VVV Ecmo. This reduces the return of unoxygenated blood. Now, most commonly a way to deal with this is the advanced VAV Ecmo. In this, we put another line, that is, one line is there in the femoral artery, and the second line that provides oxygenated blood into the IJV. Now, this gives you an oxygenated blood. So even when we are waiting for the heart and the lung to recover, during this time, the upper part of the body will also receive the oxygenated blood. So the veno-arterial venous Ecmo can be used to overcome this differential hypoxia in these patients. Then left ventricular overload leading to pulmonary edema. Now we see that the left ventricle is still receiving some blood from the pulmonary and the bronchial circulation, and it cannot be fully unloaded. Retrograde flow creates additional afterload to LV, and this leads to distension, LV distension, increased wall stress, and end-diastolic pressures. Now, this causes pulmonary edema. So, to avoid this, there are few things that we have to keep in mind, that we are to reduce the afterload and improving myocardial contractility by optimizing vasopressors and inotropic support, ensuring optimal position of the venous cannula for best possible drainage. Very important in this way is to decompress the left ventricle, is to have a venous cannula that decompresses most of the LV. So the least amount of blood is shunted. And under these circumstances, we can use a veno-arterial to veno-venous arterial configuration. In this, again, cannula is placed into the IJV, and these are the draining cannulas. So when this is put, we have a better drainage of the venous circulation, and then we can use this to counter this and try to reduce the load on the left ventricle. The other methods that has been used are atrial septostomy. This is mostly a lot of centers do it, but has been found to be controversial. Direct mechanical venting of LV using either transaortic or transapical routes. The transaortic is the LVADs. These are costly devices. That is a 2.5 impella that has been used to decompress the LV. This takes out blood from the LV and puts into the ascending aorta. Then the tandem heart that is being used after septostomy, that can be used to again decompress the left ventricle. So these are the things that we have to take in consideration. So limb hypoperfusion, the Nordstrom syndrome, we can take care by veno-arterial venous Ecmo, and then again these are the strategies where we can use how to cannulate and how to deload the LV to put in a VV Ecmo. So these are the various things that when we put a patient on VA Ecmo, we have to take in consideration. So in this diagram, I guess this is a much congested diagram. We see this how a veno-arterial extracorporeal membrane oxygenation with two venous drainage cannulas joined by a Y connector. Now this is very useful for patients who are having poor LV ejection fraction, and we definitely need to deload the LV for all these patients. Then veno-arterial venous, as I discussed, is very important when we can use this in patients who are having a north-south syndrome and we are having differential hypoxemia with a watershed that is we are encountering that. Then upper body cannulation using right internal jugular vein and right subclavian axillary artery. We know that these are the various techniques that can be used for various subset of patients. And we should try and use a distal perfusion catheter so that the distal limb ischemia does not occur in these patients. Bivads is not an Ecmo, but it's kind of a circuit, and an oxygenator definitely can be put in, and hence provides, and mostly it is used without that. In this, cannulas are placed in the sub-deferred position, and we try to have two different circuits, whereas the LV and iota and RV and the RA. So we try to decompress both sides of the heart in this, and we use two different rotors, centrifugal pumps, to decompress. This can be staged when we believe that the RV function has improved. We can decannulate the RV and then wait for the LV function to recover. And when this can be done, we go in. And again, we can wait for a transplantation in these patients. Coming to the veno-venous Ecmo, this has been quite in use recently, especially due to the COVID pandemic. We see this that during the VV Ecmo, the blood is drained into the circuit. Now, mostly the VV Ecmos, whereas the VA Ecmos post-cardiotomy has been central as well as peripheral. The VV Ecmos are mostly peripheral cannulation that we use in these patients. And this oxygenation and carbon dioxide is removed. Now, this is especially used for patients of respiratory failure. For in this, the configuration therefore relies on patient's own circulation. The LV is functioning good, but we want the lungs to get rest. So we see this, it is used in isolated failure of lung, unresponsive to optimal ventilatory support and medical treatment. I guess the other speakers will take care what are the indications, and to put a patient on VV Ecmo, there are definite guidelines when we have to put the also guidelines where we use a VV Ecmo, and we take into hypoxic respiratory failure with PaO2 and FiO2 less than 100, and then a Murray score and CO2 retention. Despite full mechanical ventilation, when the patients are not able to maintain oxygenation, and we have to use these Ecmos, and we have been seeing this in respiratory collapse, asphyxia, embolism, and recently COVID pneumonia. In this small diagram, we can see that there is a cannula that has been placed through the right femoral vein. Over here, it is placed just before the right atrium and the IVC junction. And over here, we are draining the blood, and it goes through the pump, goes to the oxygenator, and then there is a return cannula that is placed through the right IJV, and this cannula is placed to give a oxygenated blood to the right side of the heart. So definitely there is a mixing of blood, but yes, the patients get enough oxygenation so that to survive a part of during a period where the patient, we want the lung to recover, and or maybe in sometimes gives enough time for the patients to go for a transplant later on. So there are two techniques over here. We can see in this diagram, the most commonly used is this one, whereas a classical double VV Ecmo cannulation. In this, the femoral jugular VV Ecmo is there. The venous drainage is achieved by a large multiport cannula introduced into the femoral vein and advanced at the junction between the inferior vena cava and the right atrium. You can see this over here. There's a hepatic vein. TEE transesophageal echocardiography, if there, gives a very good clear picture where we are placing our IVC cannulas. So then again, the re-injection is performed by the arterial cannula introduced into the right IJV and advanced through the superior vena cava into the RA in front of the tricuspid valve. Now this allows the most of the oxygenated blood to go into the RV and then pumped into the circulation, whereas we bypass the lung and we get a good oxygenated blood. So this is one of the most common that we have been using during this time, during the COVID pandemic also. But then there is another technique less commonly used, but there's a double cannulation, and this is a femoral VV Ecmo. The venous drainage is accomplished via a large multiport cannula introduced into the femoral vein and advanced into the mid IVC. Now this is the draining cannula, and from the other side of the leg, what we have is the veno-vena extracorporeal membrane oxygenation. Now what we do is from the other side of the leg, we have another cannula that we position again at the site of the tricuspid valve and in the RA. Now this gives the oxygenated blood. So this is another way where we can use a VV Ecmo in these patients. Then this is the VV-Ecmo. In this, we have to have, like I said before, we should have a clear picture where we are cannulas are placed. The transesophageal echocardiography is a desirable thing at time of placement. Then an X-ray will show that this is the drainage cannula placed in the IVC just near the hepatic veins, and then this is the re-injection cannula that is being placed over here in the RA around the tricuspid area. And now distance between this is 15 centimeter. There is definitely some mixing of the blood, and the flow has to be regulated, titrated, and we have to see how the flow is moving around, and if we are getting the desirable results on this placement of these cannulas. Then we have the latest bicaval Avalon cannulas. Go to the diagram. Now these are the cannulas that we have. It has a single port entry. We can place this through a IJV. Whereas we can see this, the draining side of the cannula is in the IVC. It is draining the blood, and from the other port where it has to be directed towards the tricuspid valve. This has to be placed very securely. Now, what happens is now this blood, the oxygenated blood, it goes back to the pump and oxygenator, and then the oxygenated blood comes back from the second port of the AV cannula, Avalon cannula, and goes into the tricuspid valve. So this is how we achieve this. So we see this, the Avalon Elite is one of the most common dual lumen cannulas used in contemporary VV Ecmos. They are not very readily available, but yes, in Western world, very readily available. The dual lumen catheters they permit a single site cannulation in the upper body. This facilitates patient extubation and reduces the risk inherent to prolonged mechanical ventilation, mobilization and prehabilitation, and increases patient comfort, and may also decrease the infection risk as we do not have to place any cannula into the groin. The design for the Avalon Elite allows for bicaval drainage of deoxygenated blood at a considerable distance from the oxygenated blood return orifice. In the optimally positioned Avalon Elite cannula, this allows for very little recirculation. This recirculation is problem for all the circuits of VV Ecmos, but this has been negated by exact placing of these cannulas around the tricuspid area. Now, the deployment involves a precise placement of distal tip into the IVC and correct orientation of return cannulas in relation to the tricuspid valve. The similar principle of using a single cannula for both drain and return is implemented in paraglide dual lumen cannulas with drainage lumen significantly larger than the one for reinfusion. Now, mostly these cannulas, what they are used is around 23 French, and we have to see that we are able to get enough drainage and enough oxygenation to make the patient survive during this time. The other forms of the Ecmo, we should know them, is the extracorporeal CO2 removal. The indication for extracorporeal CO2 removal are hypercapnic respiratory failure states. The CO2 is readily removed from the blood, and the flow is required a lower less. We all know that deoxygenation happens much faster than in patients' oxygenation, in which we want to increase the oxygenation partial pressures. So for this, a lesser flow is required, and we can use a smaller cannulas, and we can remove the CO2 in all these patients. The typical cannulation, as I have discussed, these are the VVA and the VAV, peripheral VA used in the peripheral VA Ecmos. Then the quadruple cannulas, the ECPR, I guess Dr. Dahiya will discuss more on this, and both the RA, RV and LA, LV are decompressed and rested. So we see that a lot of things are coming up when we are talking about Ecmos. There are a lot of things. Most importantly, most of the centers there are centers that are very high volume centers, but most of the centers are not very high volume centers. A lot of things are coming up with personal experiences. It is being more widely adopted nowadays, and there is a movement towards a simpler Ecmo configurations. We all have believed that Ecmo is a very complicated process, and the training and the expertise are very less. With time and evolving indications, Ecmo learning has vastly increased. These devices have their inherent deficiencies, but with time and newer techniques, we are seeing a better outcome in these patients. Learning and disseminating knowledge about Ecmo is must to save very sick patients. Thank you, everyone. Thank you for patience.
Thank Thank you, Dr. Vijay. I think we have covered all aspects of any questions? Just I want to say something about removal of the atrial septostomy. It is inserted percutaneously. It will enable
So, can I get this once again?
you know your VO is like cannulate.
Yeah.
So while removing the cannula,
So we are opening up and repairing the artery. Venous, we do not require a repair, but yes, for arterial, we are opening up and repairing the artery. We are doing this. So there is a perclose device, but mostly in our setup, we are opening up. It is a costly device again. Perclose costs again around 25,000 bucks. So these are the devices. We are using this when we are doing a TAVI procedure. So we are using a perclose over there in TAVI procedures. But right now, for all Ecmo patients, we are opening up and putting up a clean suture and repairing them. Obviously, these patients are much longer on Ecmos. So we have adopted the technique of opening up, repairing, and then coming up.
thank you.
Thank you, sir. Thank you.
Next section. Overview and physiology of Ecmo. Mahesh Shah, he is the exam department. Yes, sir. Look at medicine.
हाँ वो नहीं ओपन मत करना बस साइड में कॉपी करना चाहिए ठीक कॉपी कर ले रहे हैं
Thank you, sir. I would now request Professor Suresh Rao, sir, to kindly felicitate Vijay Devannath, sir, with a memento for his insightful lecture. Thank you, sir. Now I'd like to hand over the mic to Akanshika.
Look back and get experienced. Look forward and see hope. Look around and find reality. Look within and find yourself. Are the four beautiful thoughts of life to start our day with, stated by Dr. APJ Abdul Kalam. A very pleasant morning to all the respected dignitaries, eminent guests and speakers, esteemed faculty members, seniors, my colleagues, and my dear juniors. I, Dr. Akanshika Tiwari, would like to welcome you all on this inauguration ceremony of Ecmo workshop conducted by King George's Medical University. I would like to welcome all the dignitaries on the dais, Honorable Pro Vice Chancellor, Professor Vinit Sharma sir, Dean, Faculty of Medicine, Professor Uma Singh ma'am, our guest of honor, Professor Suresh Rao sir, and Head of the Department and Organizing Chairperson, Professor GP Singh sir. Thank you, sir. Thank you, ma'am. Flowers are a beautiful way of expressing gratitude. So I would like to request Dr. Shefali Gautam ma'am to present a floral welcome to our Honorable Pro VC, Professor Vinit Sharma sir. Now I request Dr. Satish Sharma sir to welcome our guest of honor, Professor Suresh Rao sir. I would like to request Dr. Manish sir to present flowers to Dean, Faculty of Medicine, Professor Uma Singh ma'am. I now request Dr. Neil Kamal sir to welcome our head of the department, Professor G.P. Singh sir, with a flower. Climbing to the top demands strength, whether it is to the top of Mount Everest or to the top of your career. King George's Medical University is situated in the heart of the historic city of Nawabs, Lucknow. It is the city of India's most populous state, Uttar Pradesh. The city was the seat of Nawabs of Awadh in 19th century and a center of many arts and skills like poetry and chikankari. The National Institutional Ranking Framework has ranked King George's Medical University among top 10 medical colleges. It's our privilege that we are organizing this Ecmo workshop in Kgmu. Coming to our lighting ceremony, Saraswati Mahabhage Vidde Kamal Lochne Vidya Rupe Vishalakshi Vidya Dehi Namastute. अर्थात हे महाभाग्यवती ज्ञान रूपा कमल के समान विशाल नेत्र वाली ज्ञान देत्री सरस्वती मुझको विद्या दो मैं आपको प्रणाम करती हूँ. As a symbol of reverence to Ma Sharda, I request our dignitaries to lighten up the lamp for our traditional lighting ceremony. Thank you, sir. Thank you, ma'am. I would now like to begin by calling upon our very energetic and hardworking organizing secretary, Dr. Karan Kaushik, sir, to address the delegates.
Good morning, all of you. Today I am quite nervous also and very delighted also. Organizing a one-in-kind Ecmo workshop in Uttar Pradesh, that too in Lucknow, in my parent institute. I am more than honored and very humble and very gratitude because I have all my mentors, seniors, teachers with me. And I think I am the luckiest person on this earth because both the guides of my DM and MD are here with me to support me. So I'm happy for all the delegates because I'm having delegates from the Department of Anesthesia, Medicine, Critical Care, and also the perfusionists and technician and nursing staff which we have with us. So this is going to be a very interesting journey, especially the hands-on workshop and all the lectures taken by our esteemed faculty. So that's it.
Thank you, sir, for your motivational words. I would now like to invite our disciplined and dedicated Head of the Department, Professor G.P. Singh, sir, to enlighten the gathering with his welcome speech.
गुड मॉर्निंग। आप सबका मैं यहाँ पर स्वागत करता हूँ, सलाम करता हूँ, क्योंकि आप लोग सिटी ऑफ नवाब में हैं। लखनऊ इज नोन एज सिटी ऑफ नवाब, और यहाँ पर दूसरा कल्चर है पहले आप। तो आप सबका मैं स्वागत करता हूँ। इन द इनॉग्रल फंक्शन ऑफ CME वर्कशॉप of Ecmo, dignitary on the dais, General Bipin Puri, Chief Guest, and Honorable Vice Chancellor of this university, who is in Delhi because of some unavoidable circumstances, connected us with on digital platform. Guest of honor, Dr. Suresh Rao, President of Ecmo Society, President of Cardiac Society of Anesthesia, Pro Vice Chancellor Dr. Vinit Sharma Sahab, Dean Faculty of Academics, Professor Uma Singh, dignitaries of the dais, Professor Jigisa Pujara from UN Mehta Institute of Medical Cardiology, Ahmedabad, guide of Dr. Karan Kaushik, welcome ma'am, during his DM career, Dr. Arvind Dahiya, Director Critical Care and Ecmo Services, Kainas Hospital. I have been told that you are dedicated for this Ecmo services. Welcome you, sir. Faculty of my department, university, my visiting faculty, delegates, residents. Ladies and gentlemen, I extend my warm welcome to all of you. मैं आप सभी का अभिनंदन करता हूँ, स्वागत करता हूँ. General Puri is very enthusiastic personality. He always encourages for new ideas, new ventures, try to improve services in the university. And he has always been very kind to the Department of Anesthesia. Thank you, sir, for your blessings and kindness. Dr. Suresh Rao is pioneer in the field of Ecmo. Renowned personality all over the India and the world, has taken all the trouble to come to Lucknow from Chennai. Welcome you, sir. Pro Vice Chancellor Dr. Vinit Sharma Sahab, Madam, Dean Madam, Professor Uma Singh, they are pillars of the university and they are working very hard to put university in better perspective. Welcome you, sir and madam. Ecmo is nothing new. Around 35-40 years back, when I was resident or young faculty, we used to this Ecmo for open heart surgery, on pump surgery. So it's nothing new, but indications of its use has been widened. It is now more frequently being used, especially during COVID and post-COVID. In layman's term or in simple anesthetist term, Ecmo is now being used to give rest to lungs and heart so that they can recover and heal, rejuvenate. This Ecmo is a little costly machine and its disposables are more costly. But to save life of any patient is cheaper than any machine. Doctors are duty-bound to serve the sick patients, humanity, without any fear or favor. गीता का श्लोक कर्मण्येवाधिकारस्ते मा फलेषु कदाचन, डॉक्टर्स के लिए इज वेरी अप्रोप्रिएट. हमको तो इलाज करना ही करना है, मरीज बचेगा नहीं बचेगा हमको नहीं मालूम, लेकिन हमको अपना एफर्ट करना है सिंसियरली with sincerity and dedication. I congratulate Dr. Karan Kaushik and Dr. Rati, who have worked tirelessly day and night to make it successful workshop. I congratulate Dr. Karan Kaushik and Rati. In the last, I am confident that before I will leave this, my own KGMU, I will be able to establish Ecmo services in KGMU with the blessings of Honorable Vice Chancellor. With these words, I welcome you again. Thank you very much.
Thank you so much, sir, for your enlightening words. Your words have always been encouraging us to work harder. Now, here's a short clip for our audience to brief them regarding basic functioning of Ecmo.
Welcome back, sir. All systems will be prepared in a few minutes. Now, feel free to grab a cup of coffee. I'm here to assist you with a variety of tasks as best I can.
Facing a critical decision to save a family member can come at you when you least expect it. For families confronted with life-threatening heart or lung damage, we have a team of specialists who are experts in managing an advanced therapy that could save the life of someone you love. It's called Ecmo. Ecmo stands for Extracorporeal Membrane Oxygenation, and it can carry out the work of the patient's lungs, heart, or entire cardiovascular system during failure, as occurs in some severe infections or during cardiac arrest. It works by removing blood from the patient's body, oxygenating it, and removing carbon dioxide through an artificial lung before pumping the new blood back into the injured body. The Ecmo circuit is comprised of tubes and lines running from the patient through multiple checkpoints. The tubing carries liquids or gases, such as blood or medications, to and from the body. The lines power different sensors, which monitor flow, oxygen saturation, hemoglobin concentration, and more. Readings are taken along the way to let the Ecmo specialists know exactly how the entire circuit is performing. First, blood is removed from the body via one or more of the large veins, usually in the neck or groin. Once the blood is oxygenated and carbon dioxide is removed, the blood is pumped back into the body. This process gives the lungs and heart a chance to rest. A bedside Ecmo specialist is with the patient 24 hours a day to ensure that everything functions properly. The primary intensive care team and the Ecmo physicians coordinate their work for optimal conditions that favor a patient's rapid and complete recovery.
Systems are now fully operational.
I hope you all liked the video. I would like to request our respectful and elegant Dean, Faculty of Medicine, Professor Uma Singh Ma'am, to bless us with her kind words.
Good morning, everybody. The guest of honor for today, Dr. Rao, Dr. Vinit Sharma, Pro Vice Chancellor, Dr. G.P. Singh, Head of the Department of Anesthesia, guests for today's workshop, faculty of Department of Anesthesia, residents, ladies and gentlemen. I suppose the Department of Anesthesia itself is such a formidable force, not just in numbers, but probably now in capabilities and working also. Yeah. I think the number of faculty and this thing is residents and faculty calls for not just one department. It is like a whole faculty of some place, which is like that. What is so nice is that a couple of years back when we were looking for fine branching for super speciality or subspecialties in any department, probably anesthesia was one of the first ones to be thought of. And it's been quite some time since I have been hearing a pediatric anesthetist, a neuro anesthetist, a cardiac anesthetist. And there have been so many times when efforts were made to advertise posts, to get faculty. And I think Karan has been the pioneer, probably, one who has come as a super specialist joining the Department of Anesthesia. So it is so nice to have, and I'm sure every head of the department is actually strong only because its faculty is strengthened, empowered, and capable. And here you have variety of workshops and activities going on. I suppose it is one at least per month, or maybe sometimes even more. I had never thought that Ecmo would be one topic which they would be, discussing and talking about, especially because I thought there was one Ecmo machine in CTVS. Once we were having at the time of COVID some discussion where it was planned, obviously for COVID patient management, looking for where are the ECMOs. And frankly, to a naive like me, I understood ECMO then only. I don't remember having read in my MBBS course ECMO or ever have read, because I'm from OBGY where ECMO usually is not talked about. We talk about some other anesthesia upgradations, but not ECMO. So at that time, I heard there was an ECMO machine in CTVS. I do not know whether it is working, functioning, or used frequently or not. But it is a landmark decision of Department of Anesthesia to conduct a workshop, even without having a machine, because I agree. Once you do this, your point gets strengthened that you need this. There's no doubt about it. So today there may be many people who just hear about it, maybe retain some knowledge, maybe forget about it. But I'm sure the administration would understand by the discussion on ECMO that it is high time an institute like Kgmu procured ECMO. Because if not us, and then in North India, which other institute would have ECMO? So my best wishes to the department. I hope it comes very soon, much before Dr. GP Singh leaves. Of course, I can't wish before I leave, but definitely much before Dr. GP Singh leaves, the ECMO should be there. It is the advancements in any subject which actually keep the momentum going. Stagnation always leads to, in fact, a retrograde flow, because stagnation does not allow stagnation. The stagnation actually pulls you back. So efforts of going forward only take you stagnation level or going forwards. So it is a very, very nice time, I would say, to the department, to the residents of anesthesia, that you are joining your PG program in this department in these times, because yes, there have been times which were not so great, but I'm sure what is happening now would always take you forward, in the sense that whenever 5 years down the line or 10 years down the line, you will be able to say with great pride that you did your PG from Kgmu. Thank you very much for inviting me.
Thank you, ma'am, for showering your blessings on us. I feel extremely delighted to welcome our persevering and determined Pro-Vice Chancellor, Professor Vinit Sharma, sir, and would like to request, sir, to address the gathering with his encouraging words.
Thank you, Professor Rao, Suresh Rao, a guest of honor, respected Dean, Academics, Professor Uma Singh, Head of the Department, Dr. GP Singh, esteemed faculty which has joined us from outside the state, my very dear faculty members, residents, ladies and gentlemen. I've been told that we have got 2 ECMO machines in our college, and one is being procured. And it's indeed a matter of great pleasure to see that so many residents have joined today for the first Ecmo workshop being organized by Kaushik and Rati. I congratulate both of them for their effort, and of course, the head of the Department of Anesthesia, Dr. G.P. Singh, who had made consistent efforts for you all to learn. And they're having all AC, ALS, BLS, ACLS training all over, not only our college, but we are catering to almost northern part of India. These trainings do matter a lot and help a lot. And ECMO is one thing which COVID has taught us might be useful in patients with, of course, cardiac and lung damage. As rightly mentioned by Professor Uma Singh, you are lucky enough to be in this institution. And I'm sure I'll request my Vice Chancellor and the administration will try and help you to not only procure, but make sure that you are well trained in ECMO, and this is useful in day-to-day practices of KGMC. Thank you much.
Thank you, sir, for your encouraging words. I feel highly contented to invite our guest of honor, Professor Suresh Rao, sir, President of the Ecmo Society of India, President of Indian Association of Cardiovascular and Thoracic Anesthesia, Joint Secretary, Indian Society for Heart and Lung Transplantation. I request you, sir, to kindly address the gathering and share your experiences regarding it.
Very good morning, all. It's an honor and also great pleasure to share this important occasion with you all. ECMO is an important technology in resuscitating patients with cardiac or cardiorespiratory failure. It can be used as a bridge to recovery when the underlying cause is reversible. For example, in patients with heart failure because of myocarditis, the heart is recoverable, so it just needs time. So you can put them on ECMO and give some time, the heart will recover. Same is true in case of lung. For example, in pneumonia causing ARDS, lung will recover if you give time. So you can use ECMO in these situations. ECMO is also used as a bridge to transplant. In our centers, we do see a lot of heart failure patients waiting for transplant. So sometimes they deteriorate. We'll put them on ECMO and then do the transplant. And also in severe respiratory failure because of the ILD or cystic fibrosis and so many other conditions, if there is a severe respiratory failure, we'll put them on ECMO till they get a heart. My own experience with ECMO started in 1995. Those days, we used to put the patients on ECMO in the post-cardiotomy scenario. It was veno-arterial ECMO. The results were not encouraging. That's because we were using silicone oxygenators. The technology was not well understood. Our knowledge was poor. But over a period of time, the ECMO technology has refined. So we have done around 400 ECMOs so far with more than 50% success rate. And again, initially it was cardiac surgeon's domain. They used to cannulate because it required surgical exposure of the vessels. But now we have excellent percutaneous cannula. So anesthesiologists and intensivists can do. In fact, in our center, all our cardiac anesthesiologists put a patient on ECMO 24/7. And those of you who are interested in ECMO also will be a good resource of knowledge. ELSO stands for Extracorporeal Life Support Organization. It's a non-profit international organization. It maintains the registry of all the ECMOs done over the world. So far, around 175,000 Ecmos have been done in the world. It also helps in maintaining the registry and also conducts certified courses. It also notifies also endorsed courses, and it also helps in research activities. In India, we have Ecmo Society of India. If you are interested, you can become the member of it. Ecmo has a promising future because today's world we will have so many cardiorespiratory failure in young patients, and these patients can be resuscitated with Ecmo. So what Kgmu is doing is in the right direction. I am sure this conference will help you gaining the knowledge, and all the delegates will be benefited with this conference. I also congratulate the organizing team, Professor G.P. Singh, Dr. Karan, Dr. Rati, and all the people who worked for this conference. And thank you one and all.
Thank you so much, sir, for sharing your pearls of wisdom and sparing your valuable time for us. Thankfulness is the beginning of gratitude. Gratitude is the completion of thankfulness. Thankfulness may consist merely of words, but gratitude is shown in acts. With the above words, my humble request to Pro VC sir to felicitate our guest of honor, Professor Suresh Rao sir, with a memento. My sincere request to Professor Suresh Rao sir to kindly felicitate our respected Pro VC sir, Professor Vinit Sharma sir. My humble request to Professor Suresh Rao sir to kindly felicitate our Dean, Professor Uma Singh ma'am. I would like to request Professor Suresh Rao sir to felicitate our head of the department, Professor G.P. Singh sir. I request Professor Suresh Rao sir to kindly felicitate our co-organizing chairperson, Dr. D. Manchu sir. As sir is not present. I request Professor Suresh Rao sir to kindly felicitate our co-organizing chairperson, Dr. Avinash Agarwal sir. My humble request to Professor Suresh Rao sir to kindly felicitate Professor S.K. Singh sir, head of the Department of CTBS. As sir is not present, I request Dr. Sarvesh sir to kindly receive the memento on his behalf. A little appreciation sometimes does quite as much good as all the consensuous bringing up in the world. With the above words, our humble request to Pro VC Sir to kindly felicitate Dr. Karan Kaushik Sir as Organizing Secretary with a memento of appreciation. My sincere request to Pro VC Sir to kindly felicitate Dr. Rajesh Raman Sir as co-organizing secretary for his active participation and exceptional work in organizing this CME. I am eternally grateful to Dr. Rati Prabha ma'am for her magnificent work in this CME. I request our Dean, Professor Uma Singh ma'am, to kindly felicitate Dr. Rati Prabha ma'am as co-organizing secretary with a memento. My humble request to Professor Uma Singh ma'am to kindly felicitate Dr. Shashank Kanodia sir as co-organizing secretary for his hard work and dedication. Last but not the least, my sincere thanks to Dr. Bhavya Nathani Dubey ma'am for her splendid work in this CME. I request Professor Uma Singh ma'am to kindly felicitate her as co-organizing secretary. Thank you, sir. Thank you, ma'am. At last, I would like to bring this ceremony to an end by calling upon our very enthusiastic and hard-working co-organizing secretary, Dr. Rati Prabha ma'am, to deliver the vote of thanks.
To succeed in your mission, you must have single-minded devotion. With this word, I would like to thank Honorable Vice Chancellor, Lieutenant General Dr. Vipul Puri Sir, Guest of Honor Dr. Suresh Rao Sir, Pro VC Sir, and Dean Ma'am. The heart and soul of an academic event are speakers who have come here from all over nation to teach and discuss the basics and intricacies of Ecmo. Thank you, Nikisa Ma'am, Visala Sir, Dr. Harish, Dr. Arvind Sir, Dr. Vijayan, and other speakers for joining us. An event like this cannot occur overnight. The wheels start rolling months ago. It required meticulous planning, dedication, devotion, and hard labor. I must mention our deep sense of appreciation to Medicine Department, CCM Department, CBTS Department for constant support, valuable opinion, and constructive counsel for successful planning of this workshop. I express our sincere thanks to GP Singh Sir, Monica Ma'am, Dr. D. Himanshu, Dr. Avinash Agrawal, and Dr. Akshay Anand for constant assistance. But not least, a big and sincere thank to delegates who have come here from all over India, our organizing team and supporting staff. Thank you so much. Once again, a big round of applause for our guest speakers, delegates, and organizing team and supporting staff. Thank you so much, everyone.
Thank you so much, ma'am, for wonderful words. Thank you, everyone, and have a nice day. Over to you, Dr.
Please everybody aggregate for a short tea break. We are having tea just outside.
कैसी सर मैक लगाना पड़ेगा ये इसको पता सर ये सही सर इसमें आपको क्या चाहिए सर मैक की नोट पे मेरे पास विदाउट स्पीकर नहीं हो सकता मतलब अगर आप मेल करें तो उसमें करने और मेरा सारा डिस्टर्ब हो जाता है चलता नहीं है तो लग जाता है एचडी में उसमें
Welcome, sir.
Thank you very much. Also, thank you for your deep, followed by 6 floors of steps. Will ensure that I know that now my cardiac activity is proper. Okay. So I'll now call upon Dr. Harish, who is the head of the Department of Critical Care Medicine in Narayan, Bangalore. And sir would be actually dwelling on overview and physiology of Ecmo. So handing over to you, sir.
Good morning, all. So thank you for inviting Team Kgmu, the Department of Anesthesia. See, lots of concepts we learned from the morning. One fantastic video also presented here, which tells like what is Ecmo. We go maybe a little bit in depth in terms of a bit on basic working principle and when to initiate Ecmo, when not to initiate Ecmo, and where we can put Ecmo in terms of like its utility in a medical intensive care unit and where we can use in a surgical, particularly cardiac surgery intensive care unit and all. So when it comes to Ecmo, so it's a form of extracorporeal life support. So it is now incorporated with some sort of extracorporeal CPR also. So it is also called as one of the mechanical support device like left ventricular assist device and all when the indication become cardiac. So where an external artificial circuit carries venous blood from the patient to a gas exchange device that we call it as oxygenator, where blood becomes enriched with oxygen and removal of the carbon dioxide is going to happen. So then the blood is going to be written via central vein or an artery. So this is the simplest understanding when we come across the working principle, what happens in Ecmo. So this is a bit on history of extracorporeal life support. So in 1950, first membrane oxygenator, so it's been developed in the lab. So first successful Ecmo conducted in 1971-72. So first successful pediatric cardiac case like came out of the Ecmo. First neonatal case, that is Esperanza, so successfully done with a weaning Ecmo in 1975 to 89. We got some sort of evidence in and around like usage of Ecmo is one of the main clinical utility, that is the VV Ecmo in ARDS, but initially data was not convincing. The like survival was hardly around 10% and all. So in 1990, standard practice for neonates and pediatrics in some centers across the globe. So by 2000, we had the standard practice in adult critical care unit, both VV and VA Ecmo. So 2009, so because of the H1N1 pandemic, we got a major paper. Okay, so that like some sort of make the attention of all the caregivers, that is called CESAR trial. So that came and published in 2009, which showed a good benefit out of using a Ecmo when we transfer the patient to a center where we have a capability of doing an Ecmo. So later, one more landmark trial. See, landmark trial, we assume they should be a therapy changing trials and all. But unfortunately, one more trial we got like in 2018, that is Evolia trial, which showed some sort of equivocal outcome. I will tell why it happened like that. So this is a bit on history. So this is how we started. Means like Ecmo successful in 1971. So usually we tell to run an Ecmo, we require a village kind of this one. So that much of like staff, experience, so lots of things we require. But now what happened? So we moved from that village to a small, some sort of compact machines, okay, with an expertise. So we used to start Ecmo with a 3-4 members itself. Not like village we required to start. So this is the first neonatal Ecmo survivor, Esperanza, at the age 1 and at the age of 21. So if you see the principle, so as I already told, desaturated blood is drained via venous cannula. So CO2 is going to be removed, oxygen is added through an extracorporeal device. So this is a simple understanding. So via another vein, okay, so it is called as VV Ecmo, or an artery, we call it as a VA Ecmo. So basically, so we want to give the oxygen when the indication in and around like respiratory and take out the carbon dioxide. When we want mechanical support, we go for the VA Ecmo. Okay, so that helps to like put the lung and heart into the rest. So we have a basic components of the Ecmo. So there will be a blender where air and oxygen is going to be get mixed. So there is a membrane. So we have the blood which like pumped, means it is going to be accessed from the venous and it goes through the membrane, and one pathway is the gas pathway. So gas is going to drag the carbon dioxide, means, and it adds to the oxygenation into the blood. So these are the components of the Ecmo circuit. A blood pump will be there, membrane oxygenator with a heat exchanger. So it is an inbuilt component in the adult Ecmo circuit. There are some controllers, multiple cannulas, tubings are going to be there. So this is the different configuration. Like we already learned in the like previous lecture also, we have veno arterial Ecmo. Okay, so this is the oxygenator. So pump from the venous access and the return through the artery. So then we have veno-venous. So access and the return is going to be through the venous system. Then arteriovenous. We don't have the pump here. So patient's innate pumping activity acts as a pump. So we don't have the pump, external pump in the arteriovenous Ecmo. So that is having a special indication. We'll discuss later. So most common configuration we have veno-venous Ecmo. So used to support severe respiratory failure, which is refractory to conventional therapy. We have to make sure to see. We know that Ecmo is going to save the life, but which should be refractory to conventional therapy. Maybe for an intensivist, what is the main indication for Ecmo? That is an ARDS. Okay. So what are the conventional therapies? You should have tried so-called lung protective ventilation. You should have tried a prone ventilation at least 1 or 2 sessions. So then we call it as, okay, it is refractory to conventional therapy, because prone nowadays it's a routine. With the background of this pandemic also, like even every small hospital they started proning and all. So if that fails, so that is an indication for VV Ecmo. Veno arterial Ecmo, so used to support both like heart in severe cardiac failure with or without the respiratory failure. So then we have arteriovenous Ecmo. So that is AV Ecmo. So basically here I told we don't need the pump. Okay. So this, the purpose, we keep it for CO2 removal. So there is something called extracorporeal CO2 removal. So it is applied not only in a general respiratory failure or maybe in ARDS when the problem is like CO2 removal. So it is being used in some sort of COPD patients and all. So why this concept comes, I'll explain later. So this is called NOVA lung, A lung. Okay, so that is the extracorporeal CO2 removal. So this is like we have initially roller pumps. So now being replaced with a centrifugal pump. So we can go up to 0 to 4,000 rotation per minute. So it can deliver a flow of 8 liter per minute. So, and sometimes we keep the same like centrifugal pump for 21 days, even more than that also, if it is running without any problem. So membrane oxygenator. So Ecmo circuit have a gas exchange device called as oxygenator to add oxygen and to remove the carbon dioxide. So a bit on this membrane oxygenator. So previously, like as Dr. Suresh told, like they started with the silicon membrane that worked as an oxygenator were used, which are being replaced currently with the hollow fiber, which is made of polymethyl pentene membrane. So these are extremely efficient at gas exchange and demonstrate minimal plasma leakage and the less resistance. See, when we flow in any sort of extracorporeal therapy, we don't want any resistance, because that again alters the hemodynamics and all. So these kind of circuits, what currently we have this membrane oxygenator, they are very minimal resistance with the less plasma leakage chance and all. So again the gas exchange, so we have something like fresh gas, sweet gas and all. So then we have multiple like pumping and tubings and all those things. So when it comes to oxygenation, okay, so we can play around. So improving the oxygenation with the type of the membrane and diffusion characteristics of the membrane. So thickness of the blood pathway, which also give an impact on the oxygenation. So surface area of the membrane means efficacy again depends upon the surface area. We can't interchange like pediatric versus that of the adult. So FiO2 in the gas phase, Means if you really want to increase the oxygenation, so one thing what we can do is increase the means FiO2. So rate of the blood flow again, which correlates with that of the oxygenation. So CO2 removal, so it depends upon the difference in CO2 between the blood and that of the gas phase. And if you increase something called sweep gas or the fresh gas, we can just come out with that of the more and more CO2 removal. So heat exchanger, as I told, in adults, it is usually built with the oxygenator. So in pediatric cases, it is connected separately after the oxygenator in the circuit. So definitely it helps in maintaining the temperature regulation. See, I told something called eCPR and all. So one protective mechanism for brain, we have something called therapeutic hypothermia. Suppose if you done a eCPR, means Ecmo based CPR, and you want to protect the brain with a therapeutic hypothermia, so targeted temperature management. So obviously we can do temperature control with the Ecmo circuit also, because we are using Ecmo for the CPR. So then we need to protect the brain. So with the temperature achievement somewhere around 34 to 36 degrees Celsius, that we can control the Ecmo also. Again, Ecmo cannula, we have aortic, which is a wire wound almost to the tip. So it is having a single outlet hole. So when it is venous, which is going to have the multiple holes. So sometimes, so in spotters and all, they used to keep for the exam to identify which cannula it is. So this is how we can indirectly identify the cannula. So as I told, we have one configuration, that is veno-venous Ecmo. So in that, depending upon the site which we are going to choose, which have some sort of pros and cons, some advantages, some disadvantages. There is femoro-femoral, so high flow like veno-venous Ecmo cannulation, femoro-jugular, and we have something called Avalon, that is a double lumen. So single cannula, which serves as the purpose of two lumen, which is used for the VV Ecmo. So when it comes to femoro-femoral, so access cannula is inserted via the femoral vein with the tip sited within the IVC. So return cannula is inserted via contralateral femoral vein with the tip in the right atrium. Very important to identify where exactly is the tip. So advantages, we can put it quick, safe to insert, easy to secure the cannula. So disadvantages, limited maximum flow rates, because I told flow rates we can adjust to improve the oxygenation also. When we need more and more flow, so then sometimes it may not be possible. Often requires conversion to a high flow configuration. So in the high flow configuration, what we are going to do is uses the same bifemoral cannulation, an additional short access cannula we put in the right internal jugular vein, so which allows higher circuit blood flow as they draw blood from the great veins, both from the SVC and that of the IVC, because it is an additional access source. So it is required in severe cases of respiratory failure when we are struggling to achieve the goal of oxygenation. So whatever the cutoff for SpO2 or the PaO2. So disadvantage is it occupies three major veins. Okay, so relatively complex to secure and dress the jugular cannula. So patient remains bed bound. See, nowadays in my unit also we take the patient out of the bed once we initiated the Ecmo. So even VV Ecmo, stable hemodynamically, we mobilize them out of the bed and all. When we occupied with the three major veins and all, it's a bit cumbersome to mobilize, initiate early physiotherapy and all. So potential source of air embolism, so pressure injury, infection, we know that more the lumen, more the major vessels we are going to occupy, more chance of bloodstream infection and all. So femorojugular, so access cannula via femoral vein with the tip sited just below the inferior cavo arterial junction. So return cannula, so it is in the tip in the lower SVC into right internal jugular vein. So advantages, nearly can provide adequate support, means we can achieve the adequate flow up to 5 to 7 liters per minute. So disadvantages are relatively complex to secure and dress the jugular cannula, require 2 sterile field to be done during Ecmo cannulation. So access insufficiency can be more difficult to identify in early stages without the negative pressure monitoring. So we need to assess negative pressure monitoring, transmembrane pressure and all those things. So double lumen cannula, so this is some sort of recent advance, that is an Avalon cannula. So initially there was non-availability of this double lumen cannula in India, but now we have this Avalon supply also. It is a single cannula with a 2 lumens for access and return inserted via the right internal jugular vein. So single vein, so single cannulation allows movement from the bed and ambulation. Early physiotherapy and logistics are very good with the Avalon cannula. So disadvantage is care on insertion to avoid right ventricular placement and rupture. See, even I lost one patient, so around 38-year lady, while putting this cannula, because so very catastrophic problem is it can cause some sort of the rupture of the right ventricle if not trained properly. Even it's been means done by a cardiac surgeon in the beginning days. It is almost 4-5 years back. So difficult to position return port towards the tricuspid wall. So that is appropriate position is toward the right tricuspid, means tricuspid wall. So that is sometimes difficult with the Avalon achievement. So then we know arterial, we have standard femoral cannulation, emergency femoral cannulation, high flow cannulation, so central, okay, specialized cannula, central bypass cannula. So these are the different configuration when it comes to veno arterial. So you have to remember, see, when we start with the ECMO, initially it may be VV ECMO. Many of the critically ill patient, when our indication is straightforward with the ARDS and all, but sometimes overnight we need to convert into veno arterial and all on emergency basis when they have worsen shock and all. So in the standard femoral, so we have access cannula is inserted via femoral vein with the tip in the right atrium. So return cannula via common femoral artery with the tip lying in common iliac artery or lower aorta. So advantages, which provides full or partial cardiac support. So risk of differential hypoxia will be there when the flow is not matching. So may need conversion to high flow configuration. So if a native cardiac function improves in the setting, means like we put veno arterial ECMO with the consideration support for both the lung and heart. If the innate cardiac activity started improving, which may lead to some sort of differential oxygenation and all. So in the emergency femoral VA ECMO, it is similar to standard femoral, but uses a smaller cannula. So we can convert immediately a VV ECMO into a veno arterial ECMO with a smaller emergency cannula, which is a little bit 19 to 21 French as compared to standard cannula size, that is 21 to 25 French. So advantages, faster to insert, use it for ECMO CPR or in the peri-arrest patient. As I told, when we need urgent conversion and all. So again, down the line, there is a risk of differential hypoxia with the emergency VA cannulation and all. High flow cannula, so additional access cannula, as I already told, we use again one more source for the access in the intrajugular vein. So used to minimize the differential hypoxia when native cardiac function is going to be returned or improved. Then the tubings, nowadays we have most of the centers we use heparin coated tubing. Sometimes we stop heparin. So when the ECMO is running for some sort of intervention, that is possible because nothing is going to happen in terms of clotting because most of the circuits are heparin coated nowadays. Even though we monitor ACT when the patient we given heparin infusion and all, sometimes we interrupt the heparin infusion for any sort of intervention if required. So basically, as I already told, we discussed lots of things. What is the indication for ECMO? So remember, ECMO is a bridging therapy, not a curative therapy. Okay, so we utilize the ECMO to give the rest to the lung or heart. Okay, so till the primary pathology, what initiated all these things are going to be settled. So it is not a curative therapy; it's a bridging therapy, bridge to recovery, buying time for patient to recover. So if the insult is ARDS, we know that it's having its own phase, okay, up to the fibrotic phase and all. So what triggered, we control the source, given an antibiotic, fluid management, congestion, so deresuscitation, everything we done. So during that time, so it gives additional time for the recovery of the patient, recovery of the lung. So bridge to decision. So provide temporary support to patient and allow clinicians to decide on the next step. Okay, so bridge to transplant, provide support to patient while avoiding suitable donor organ. So as I told, we do lots of VV ECMO nowadays also. So yesterday also we have initiated one VV ECMO for an interstitial lung disease patient who's been listed in the lung transplant list. But unfortunately, after initiating, he started having total acute kidney injury, renal shutdown. So with the VV ECMO, we initiated him on the CRRT currently, but he might not survive also. So bad progressive interstitial lung disease and worsening is because of the triggering infection on him. So we thought, okay, we can reverse that infection, and by the time we can get the organ transplant processing and all. So what are the indications for ECMO? So we know that one organization which gives updated indication, that is ELSO. So ELSO guidelines which suggest acute severe cardiac failure or respiratory failure with a high mortality risk and reversible and non-responsive to optimal conventional therapy. See, each word is very, very important. So remember, so when we have some sort of irreversible underlying pathology, so sometimes my colleagues will ask, means my other department, so patient is a case of acute myeloid leukemia, okay, with some sort of very less chances, even though after the bone marrow transplant and all, they deteriorate, so they will ask for the Ecmo initiation and all. So we need to understand whatever the pathophysiology we are initiating, that should be reversible. Okay, we started doing Ecmo for some sort of the toxins also, like poisons, understanding some reversibility will be there even when we initiated the Ecmo, and they are considered non-responsive to optimal conventional therapy. You need to define what is optimal, what is conventional. As I already told in ARDS, so we need to initiate first the lung protective strategy. So then if it is failing, so then we'll opt for the VV Ecmo, because like in India, so everything comes with a cost. So we can't like, we moved like more and more often, more frequency has increased in the usage of Ecmo, but we need to understand conventional therapy is the first. So extracorporeal life support is considered at 50% mortality risk and indicated at 80%. So what exactly it means suppose you tried the conventional therapy, so even after that, if you are feeling, so there is a 50% chance of mortality is not responding. That is the thing we started discussing, and definitely it is indicated when we assumed with our previous knowledge, with the evidence, the mortality is going to be somewhere around 80% after the conventional therapy. So ELSO guidelines for adult respiratory failure. So the inclusion criteria in hypoxic respiratory failure due to any of the cause, whether it's a primary, when primary means it is in and around the lung, or secondary means sepsis ARDS. So it is a secondary involvement of the lung. The patient is having a skin soft tissue infection, severe sepsis, he had an ARDS. So that is the secondary respiratory failure. So 50% mortality risk associated with the PF ratio of less than 150 means, so he's having a moderate to severe category of the ARDS. So with already requiring FiO2 of more than 90%, there is some objective criteria to take a call on initiation of Ecmo, that is called Murray score. We'll like discuss later, when the score is somewhere between 2 to 3. So 80% mortality risk is associated with the PF ratio of less than like 100. So obviously patient is in severe category of the ARDS according to Berlin's category, with a FiO2 of more than 90%, Murray score 3 to 4, CO2 retention and mechanical ventilation despite high P plateau. So sometimes we used Ecmo for severe status asthmaticus patient also, just for supporting respiratory system for the removal of carbon dioxide, and to get some more time for additional therapy to act in terms of reducing the bronchospasm and all. So need for intubation in a patient on lung transplant list with a background of primary pulmonary fibrosis, interstitial lung disease, cystic fibrosis and all. So immediate cardiac or respiratory collapse like pulmonary embolism, blocked airway, unresponsive to optimal care. See, last week we had a patient, so bit of obese, like walk means like came to emergency department with a evaluation for acute respiratory distress because of obesity, bedridden and all. We have done a CT pulmonary angio, which clear cut showed like saddle thrombus with a bit of unstable hemodynamics and all. Clearly it is an indication for thrombolysis. But unfortunately, the patient visited the previous small hospital where they attempted putting a Foley's catheter. Patient started having a huge hematuria. So then, like giving a systemic thrombolysis in that condition, it is almost relative to absolute contraindication. We initiated the patient on Ecmo, like there is a VA Ecmo, because patient was in shock. Okay, so even though we know that we need heparin, but we have a heparin coated like circuits currently, so we thought we have taken the risk and we initiated. In the next 48 hours, hematuria settled and patient survived out of like this pulmonary embolism. Otherwise, it's a catastrophic outcome. So that is like acute cardiorespiratory collapse. That is one of the indications. So this is the Murray score, which have 4 major parameters like PF ratio, chest X-ray criteria, PEEP requirement, and that of the lung compliance. We know that. So we monitor the lung compliance at the bedside by putting the patient on end inspiratory hold, that is the P plateau. So sometimes in an obese patient, that is not an ideal way. So we need a esophageal pressure monitoring system and all. But currently our take home is when the P plateau is somewhere more than 30 on an individual basis, we think okay, compliance is bad. So that is the end inspiratory P plateau. So these are the criteria to have an indication, that is called Murray score. So there is something else called Oxygenation Index, that is equal to mean airway pressure into FiO2 divided by PaO2 into 100. So even though we don't follow, but there are some indication for initiating the Ecmo based on oxygenation index criteria. So commonly used criteria include 2 oxygenation index, okay, more than 40 within 1 hour time span, or 1 oxygenation index of 60 on high frequency ventilation, okay, or one oxygenation index 40 combined with cardiovascular instability, means patient is requiring some sort of vasoactive agents to support his hemodynamic system. So that is the oxygenation index. So in terms of final indication, that is the rationality when we start thinking about the ECMO. So what caused the pathophysiology for respiratory failure? It may be ARDS, severe pneumonia, severe acute asthma, chemical and inhalational hypersensitivity pneumonitis, near drowning, post-traumatic lung contusion, because lung contusion mimics that of the ARDS, and the therapy initially it is lung protective ventilation. So bronchiolitis obliterans, autoimmune lung disease like severe vasculitis, good posture syndrome and all. So irreversible or chronic respiratory failure, it is indicated as a bridge therapy, as I already told. So when we listed the patient for the lung transplant, we can use, we know that, so patient is having a severe irreversible respiratory failure, but we have some sort of final therapy, that is a lung transplant, and is been listed. So contraindication, there is no absolute contraindication to extracorporeal life support when the indication becomes respiratory failure. So it is like your capability to manage the complication associated with the ECMO. So we have a standard set of means contraindication, that is absolutely coagulopathic conduct. But otherwise, as an indication, we don't have any real contraindication when it comes to respiratory failure. So relative contraindication due to poor outcome, mechanical ventilation at high setting, like someone who is requiring a FiO2 of more than 90%, P plateau, that the compliance is very bad, more than 30 for 7 days or more. So usually in my unit also, we consider if the illness is more than 7 to 10 days, we go slow on indication for the ECMO, and we think, okay, we'll not jump on initiating ECMO. Really, if it is more than 10 days, we'll avoid using the ECMO when it is an ARDS indication. So major pharmacological immunosuppression, like I told, AML patient with absolute neutrophil count of less than 400. When we have irreversible primary pathology, so it is some sort of relative contraindication. CNS bleed, which is recent or expanding hematoma. So non-recoverable comorbidities such as major CNS damage, terminal malignancy, age, no specific age contraindication, but we know that as the age increases, the success outcome of the ECMO will go down. So we have a cutoff like 65 to 70 years. Again, we'll think whether to initiate ECMO or not in our unit. ALSO guidelines for cardiac failure. So inadequate tissue perfusion manifested as hypotension and low cardiac output despite adequate intravascular volume. So that is how we define cardiogenic shock also. There should be adequate intravascular volume. So cardiac index is low and is manifesting with a multisystemic hypoperfusion. So there is an increasing lactate, drop in urine output, cold peripheries, capillary refill is time is more than 3 seconds and all. So then we think about initiating the ECMO. Shock persists despite volume administration, ionotropes, vasoconstrictor and IABP. So then there is also one of the indication in terms of the cardiac indication for ECMO. So typical causes which make think about the ECMO, acute myocardial infarction. We have something called MACE, major adverse cardiac events after MI. So it may be like capillary muscle rupture with a myocardic mitral regurgitation and all, or ventricular septal defect or free wall rupture. So all these things makes some sort of indication as an acute MI background for initiating ECMO. Myocarditis, severe viral myocarditis. So with a cardiogenic shock, it makes an indication. So decompensated chronic cardiac failure, post-cardiotomy shock. So most of the time, so when we consider VA ECMO, so this is the scenario. Even in pediatric cases also, we do lots of ECMO with a post-cardiac surgery indication and all. Peripartum cardiomyopathy. So septic shock. So even though don't have a huge data in and around septic shock, but so nowadays we are exploring, okay, when we have a reversibility in terms of adequate like source control with adequate antibiotics and all. So ECMO advantage in cardiac failure, it is a biventricular support. So bedside immediate application and oxygenation in biventricular failure. So refractory malignant arrhythmias we can consider like refractory arrhythmias, ventricular tachycardia and all. Heart failure with severe respiratory failure. So it supports both heart and that of the lung. So ECMO as a bridge. So in acute MI after revascularization, so myocarditis, so when the patient is being listed for the transplant. So contraindication, we have absolute contraindication when it comes cardiac indication. So unrecoverable heart and not a candidate for transplant or ventricular assist device. So there is no fun in initiating the ECMO. We don't have any permanent solution for that heart. So chronic organ dysfunction, like with the cardiac indication, patient is having a severe emphysematous chest, cirrhosis is ongoing with ethanol like background and all. So renal failure, which is CKD patient and all. Prolonged CPR without adequate tissue perfusion means the effectiveness of the CPR is questioned, so then it is not an indication for initiating the eCPR. So relatively, like patient was on anticoagulation, so morbidly obese or advanced stage. So these are relative contraindications. So we have to individualize all these contraindications. So when it comes to severe ARDS, when we initiate Ecmo as an indication, as a basic indication in a medical ICU that is ARDS, we need to take a call whether we are initiating Ecmo for hypoxia region or it is hypercapnia. So when it is like oxygenation is the indication, so we need to assess is the patient requiring any sort of support for his hemodynamics or is well-maintained hemodynamics. So if he is having no shock, then straight away we'll consider for venovenous Ecmo. So if the shock is there, if the shock is because of the severe RV dysfunction, maybe hypoxic pulmonary vasoconstriction or severe hypercapnia, PEEP or poor compliance will put a pressure on the RV. If that is the scenario, still we have an option for VV Ecmo. When it is biventricular or LV is the cause, so straight away we go for the veno-arterial Ecmo. So if the problem is hypercapnic respiratory failure, see sometimes in the prone and all we are able to achieve oxygenation, maybe PA of more than 55, PF ratio of somewhere around 180 to 200 and all, but the problem is we are not able to come down on the carbon dioxide, even though we accept so-called permissive hypercapnia. It is 120, 130 and all, so then we can take a call on initiating the patient on Ecmo for ARDS reason. So then again the question is the hypercapnia associated with hypoxemia? Then we go for the veno-venous Ecmo. So if it is without hypoxemia, we have something called A-lung, Nova lung. It is also called as respiratory dialysis. Okay, to take out only carbon dioxide when we have an adequate oxygenation. So that we also call it as a low flow Ecmo. Okay, so this is the rest lung setting when we initiate the patient on Ecmo. So hardly we'll give 3 to 4 ml of the per kg of the tidal volume. So respiratory rate somewhere around 8 to 10. So we'll keep PEEP of around 8 to prevent the collapse of the lung and all, which we have many sessions on this. We'll discuss on this. So like reasonable target when a patient is on Ecmo. So keep hemoglobin saturation of more than 90% for VA Ecmo and more than 75% for VV Ecmo. So then adequacy of the perfusion, get an idea about the urine output, how is the lactate trend and all, so how is the peripheries and all those things. So pump, we are going to have the like flow somewhere around 100 to 120 ml per kg per minute. So sweep gas is the one which we play around in terms of removing the carbon dioxide. So that we keep around 1 to 2.5 liter per minute for 0.8 meter square circuit membrane and 1 to 4.5 liter per minute. That is the adult Ecmo. So we keep that amount of the fresh gas flow or the like sweep gas flow. So this is how we can adjust in terms of like sweep gas and that of the FiO2 adjustment. So take home here is if you want to really troubleshoot the carbon dioxide, so play with the sweep gas, that is the fresh gas, or if you want to improve the oxygenation, it is the FiO2. So this is the algorithm which we can follow. So we have the session like how to initiate and troubleshoot an Ecmo and all those things. So basically, like this is the evidence which happened in the last decade, 1.5 to 2 decades on Ecmo. Even before the COVID and all, we have a pandemic H1N1. I told like in 2009, so one trial, that is a Cesar trial, which came into picture, which showed a fantastic mortality reduction if you refer a patient to Ecmo center. There was a problem in that trial because whatever the standard group of patients, they have not even received the lung protective ventilation. So which obviously showed if you shift the patient to Ecmo unit, very good reduction in the mortality. So to overcome that bias, we had one more trial, that is the Evolia trial. Okay. Here they kept some criteria for a crossover. Means okay, if patient is deteriorating in terms of his PF ratio with a standard way of care. So from the standard care group, we can move them to the like some sort of Ecmo indication and all. Again, which is equivocal. We need to understand. So to get that a significant reduction in the mortality with a p-value of less than 0.05, we need to enroll more and more, maybe around 6,000 patients for these kind of trials. That is not possible. With that background, we got this meta-analysis, which clearly suggests, considering all these intricacies of indications and the evidence, definitely Ecmo is having a role in saving the patient with this meta-analysis. So this is the range of extracorporeal therapies we have. I told there is something called extracorporeal CO2 removal. Okay, here the flow is hardly around 1 liter per minute. Indication is very clear. So it is not for oxygenation, it is for the removal of carbon dioxide. Maybe in a refractory case of COPD, refractory case of ARDS, if you achieve the oxygenation, so we can use this so-called extracorporeal CO2 removal. See, I told lung protective ventilation. So when we speak about lung protective ventilation, we go tidal volume up to the 6 ml or less than that also. When you do that, it is at the cost of increase in carbon dioxide. Okay, so we are allowing permissive hypercapnia. If that permissive is beyond the range, then what we can do is we can put this extracorporeal CO2 removal. So then we can consider giving very low tidal volume, allow the CO2 to build up, that we can take care of the extracorporeal CO2 removal. So that is indication. So lots of data available in terms of this one modality that we call it as low flow Ecmo. There is something called ultra lung protective strategy where they are trying to use 2 ml per kg of the tidal volume. So they allowed CO2 to build up, take out with this extracorporeal CO2 removal. So that is called ultra protective lung strategy. The trial is supernova trial. So it has been completed with the recruitment and all. So in terms of medical intensive care, as I told, major indication is ARDS for VV Ecmo, where we fit this VV Ecmo in a moderate to severe category of the patient. But remember, one thing which helped throughout the life of a patient who had a ARDS, that is a low tidal volume. So remember, low tidal volume. Okay. So, but we have other therapies which helped in terms of reducing the mortality according to the severity of the ARDS. So we have lots of other therapy. One therapy is Ecmo in moderate to severe ARDS, which saved the life. To conclude, so Ecmo is indicated both in cardiac and respiratory condition. So it is one of the modality of extracorporeal life support in cardiac arrest, what we call it as eCPR. So initiation always depends upon risk-benefit assessment. So early and safe referral is the key for a good outcome. So it is not a curative therapy, very, very important. It is a bridge for any modality of the therapy to work, to get some additional time, but definitely helps in achieving definitive therapy for the underlying indication. Thank you.
Thank you, sir. We will be the next lecture. Our next speaker is Professor Suresh Rao. And I have the honor of calling Professor Suresh Rao, who we know is the president of Ecmo Society of India, and also president of Indian Association of Cardiovascular and Thoracic Anesthesia, joint secretary of Indian Society for Heart and Lung Transplantation, and presently the co-director of the Institute of Heart and Lung Transplantation and Mechanical Circulatory Support. Handing over the mic.
Okay, good news. वीडियो से बहुत मुश्किल होगी चले वीडियो को जस्ट पुट इट एक मिनट
So very good morning. I am really excited to see so many people interested in Ecmo. It has a good future. I think it is worth learning this skill. That is MGM Healthcare, where I am working. Basically, I am involved in heart and lung transplantation and also various mechanical circulatory support services like LVAD, BiVAD, and of course Ecmo. So in the next 15 minutes, I will share our experience of Ecmo in COVID-19 pandemic. All of you know that the COVID-19 basically affects the respiratory system. Majority of the patients will come out with just oxygen or high flow nasal oxygen, or sometimes by NIV. Some patients may have severe hypoxia requiring mechanical ventilation. There will be a small set of patients, in spite of putting them on ventilator, their oxygen saturations will be too low. So those are the candidates for Ecmo in institutions with appropriate resources. It is used as a bridge to recovery or as a bridge to transplantation. Now the criteria we used for instituting the Ecmo is almost same as the criteria in ARDS also. PF ratio less than 150 with a plateau pressure of more than 30 centimeter of water with FiO2 of more than 90%, or if the PCOT is more than 80 with the pH of less than 7.2, or with the Murray score of more than 3. However, it is reserved as a last resort. We try various strategies like prone positioning, giving optimal peak, various recruitment maneuvers, use of neuromuscular blocking drugs so that the ventilation is optimized. Sometimes they may have pulmonary hypertension, so pulmonary vasodilators also you can try to improve the oxygenation. And majority of the times it is veno-venous Ecmo. Of course, in some cases we used veno-arterial Ecmo also. So if the patient has got cardiac failure in addition to respiratory failure, especially right ventricular dysfunction or pulmonary embolism, or if they have acute myocardial infarction, sometimes MI can happen in COVID-19 patients because they are hypercoagulable, or acute myocarditis. All these conditions we use veno-arterial Ecmo. So coming to the contraindications, if the patient has got multi-organ failure, or if they are in advanced stage of malignancy, if they have severe neurological injury, or if there is any CNS hemorrhage, those are the contraindications. Age, ideally their age should be less than 65. I have put a question mark because we have successfully conducted Ecmo in a 80-year-old gentleman and sent him home after 20 days of Ecmo. In fact, he is owner of one of the corporate hospitals in Tamil Nadu. And again, number of days on ventilation. Usually, if it is more than 7 days, the outcomes are not so good. But we have put the patient on Ecmo even after 1 month of mechanical ventilation. Basically, these patients are shifted to our center for a lung transplant. And while waiting, their condition deteriorated. So we put them on Ecmo. So coming to the cannulation, we used a 2 cannula technique for veno-venous Ecmo. That is the femoral venous cannula as the drainage cannula, and IJV cannula as the return cannula, and it is percutaneous method. Whether that video will play. I think video is not playing. Basically, I just showed how the femoral vein is punctured, then we put the venous cannula. This is the IJV cannulation. That is the single cannula with the 2 lumens. The one lumen drains the venous blood, and the oxygenated blood is given back through the other lumen into the right atrium. Sorry, that video is not playing. So the management of Ecmo, once it's very important. We go for rest ventilatory settings. As Dr. Harish indicated, we go for tidal volume of 4 ml per kg. We maintain an optimal PEEP to prevent any collapse. And we give 60 to 70% of the cardiac output as Ecmo flow, so that our target oxygen saturation is around 80 to 90%. So if the saturation is low, we will increase the Ecmo flow. Sometimes you may not be able to increase the ECMO flow because of the poor drainage. So first thing, we will give volume. If the drainage improves, fine. If not, we'll put one more cannula in the other femoral vein to have a better drainage. But despite of all these measures, if the saturations are low, we will give blood to increase the hemoglobin and oxygen carrying capacity of the blood. Some patients may require pulmonary vasodilators, especially if they have pulmonary hypertension. Now, anticoagulation is very important. They will have a hypercoagulable state. So usually we go for APTT of 2.5 times the normal. Sometimes, most of the time we will use heparin. Sometimes we used bivalirudin also. However, what we have seen is some patients will have coagulation, some patients will have bleeding. So we started monitoring the anti-10 ASA. So we try to maintain the anti-10 ASA between 0.3 to 0.6. Coming to the weaning, as the saturation improves, the lung compliance also improves. So we started weaning the Ecmo. So we reduce the FiO2 on the sweep gas flow. If the SATs are maintaining, then we'll start reducing the sweep gas flow also. And we'll monitor the PCO2. And finally, we'll switch off the sweep gas flow, run the ECMO for 24 hours. If the patient is fine, maintaining oxygenation and CO2s are normal, then we'll take out the ECMO. Of course, we have seen various complications, mainly GI bleeding. Some patients require endoscopy and endoscopic procedures to control the bleeding. Patients had bronchopleural fistula and they had repeated episodes of sepsis. And we had an overall mortality of 40 to 50%. Especially in the first wave, we had higher mortality. In the second wave, probably we had better results. Maybe because with the experience, we became better and patients also presented in the early stage. This is one multi-center study from Korea, South Korea, and they had a mortality of 54% for ECMO for the COVID-19 patients. This is from the ELSO registry. The first 1,093 cases, they had a success rate of 37%. Had a mortality of 34%. Remaining patients either shifted to other centers or they were still on ECMO. But the latest data shows so far around 12,500 ECMOs have been done for COVID-19 pandemic with outcome of around 50% survival. So we have done around 119 ECMO for COVID-19 ARDS and with survival rate of 40%. And we also did 19 lung transplants for COVID-19 ARDS. So when the patients are not coming out of ECMO even after 1 to 3 months, and if the lung is totally damaged, so we did the bilateral lung transplant. Out of 19, 14 survived. I will just present some cases just to make you understand what is possible. So this is a 37-year young man, no comorbidities. He had COVID-19. He got intubated. His saturation didn't come up. So he was put on ECMO. On ECMO, his tidal volume was 50 ml per kg. Sats were 80%. It was coming down. So he was airlifted to our center. They used the isolation pod because patient was still in the infective period. This was his chest X-ray when he came. You can see the ECMO cannula. And over 25 days, his saturation started improving, tidal volume improved, compliance improved. So we started weaning off the ECMO. This is the chest X-ray after 25 days of ECMO. And we could decannulate him. Of course, he required a lot of physiotherapy. We used the Lato machine to give active physiotherapy to the leg and the upper limbs. Again, video is not playing, sorry. So this is 3 months after the discharge. He's gone back to his regular work. In fact, he is an anesthesiologist and started giving anesthesia. Case 2, a 35-year young lady had COVID-19. She was on Ecmo for 35 days. She had a GA bleed and it required endoscopy and clamping of the bleed. I hope the CT will play because I'm sorry that you could actually see the CT before the, is it playing? So her lung involvement was complete, 25 by 25, and after 35 days of ECMO, the lung recovered completely, and she has gone back to. Okay, next slide. That's fine. This is her picture in the recovery period. This is another case, 40-year-old from Ahmedabad, weighing 100 kg, severe COVID ARDS. He was on ECMO for 40 days and finally he recovered, so we decannulated. But after 1 week, again, his saturation came down. He had bilateral pneumonia. So we put him back on ECMO, and this time we supported him for 1 week and the lung infection recovered, so we could decannulate and send him home. This is during the recovery period. And we had annual conference by the ECMO Society of India. In fact, he came for inauguration of the conference. You can see him lighting the lamp. This is another case where the patient had severe COVID-19 ARDS. He was on a ventilator for 1 month. He was shifted to our center for a transplant. And while waiting for the transplant, his condition deteriorated. So we put him on ECMO. So this was his CT chest. The lungs were totally destroyed. So he was on ECMO for 1 month. And then we did bilateral lung transplantation. And this is in the bronchoscopy during the post-transplant period. I think all the videos are not playing. So this is his explanted lung. The lung was totally destroyed. And we also did a histopathological study where you couldn't see the pneumocytes. The mitochondria were destroyed, no Golgi apparatus, so totally destroyed lung. So this is his, then very second day we could take off the ventilator. This is his chest X-ray post lung transplantation. And he took 1 month to recover and finally we could send him home. We also published our data on the ECMO for COVID-19 ARDS. In fact, it was one of the first from India. So that is lung transplantation for COVID-19 associated ARDS, international experience of first national transplants. We also published our data in the ISHLT meeting in 2021. So this is another VIP who came to, he was having severe COVID-19 ARDS. We put him on ECMO, airlifted to our center. His lungs did not recover. Then finally we did the bilateral lung transplant. So he went back to his state, Jharkhand. In fact, he is the education minister of Jharkhand and he was received by the CM. So to conclude, it is used as a bridge to recovery. It can be used as a bridge to transplant. Sometimes we have used ECMO as a bridge to recovery of the transplanted lung whenever there was primary graft dysfunction. And it requires a large team, committed team. So with this, thank you. Any questions, I'll be happy to answer.
The session is over. Thank you, sir. I now request Professor Jyotsna Agarwal ma'am to kindly felicitate Dr. Maheshwarappa sir for his wonderful lecture. I now request Professor Suresh Rao sir to kindly felicitate Professor Jyotsna ma'am with a memento. Thank you, sir. For the next session, I would like to invite onto the stage our the chairperson for the session, Professor Dinesh Kaushal sir. He is a professor in the Department of Anesthesiology and Critical Care here at Kgmu. Welcome, sir.
मैम कौन सा है बताइए?
For this session, our first speaker is Professor Jasa S. Pujara. He is from the US Mehta Institute for Biology, Ahmedabad, and he will develop a topic: initiation and management of the VA Ecmo. So I invite Professor Jasa S. Pujara.
Good morning, all. I must congratulate Dr. Karan, Dr. Rati, and the team cardiac anesthesia, and particularly Dr. Singh, who helped and his anesthesia department helped for organizing such a wonderful event. My job has been now reduced because many speakers have explained about all these things, but still I will give some basic view about the VA Ecmo. Initiation and management of VA Ecmo. It's also referred as the extracorporeal life support. It's form of the temporary mechanical circulatory support and simultaneous extracorporeal gas exchange for acute cardiorespiratory failure. VA Ecmo is drained through the vein via the inflow or the drainage cannula, passes through the pump and oxygenator and return back into the artery, and via the outflow cannula or the return cannula to support the heart for the ventricular unloading, and for the hemodynamic support. It gives both cardiac and respiratory support. It is original Ecmo mode and still predominant type of the support in the most centers. Goal for this are to keep the patient alive without hurting him or her too much, to improve the tissue oxygenation and the gas exchange, to allow normal metabolism while providing the heart and lung rest, to prevent the multi-organ failure, to avoid the iatrogenic damage by the ventilatory support, higher ventilatory support and the higher inotropic supports, to allow the time for the reversible recovery of the lungs and the heart by giving rest to these organs. Basic principles are replacement therapy is like artificial lung and heart outside the body. It bypasses heart and lung completely or partially, just like the hemodialysis in the renal failure. Venous blood is drained out and the oxygenated warm blood is returned back with the force to an artery or the vein. Unlike ventilators and inotropes, which works like by the native organs like heart and lung, it works through the different pathways. So maintain the cardiorespiratory function without loading the heart and lung, and thereby give rest to these organs and allow the recovery. How does it help? It helps to sustain life in case of the cardiopulmonary arrest, provide the oxygen and removes the carbon dioxide, maintain the mean arterial pressure, maintain tissue perfusion, decreases the inotropic requirement, thereby reduces the toxic effect of these inotropes, decreases the ventilatory requirement, thereby reduces the ventilatory induced lung injury, rest to the heart and lung. History already discussed, so we'll not discuss much about this. Different variant of the Ecmos already we had discussed, like depending on the additional arterial or the venous cannula required. Hybrid Ecmo modified technology where return is both artery as well as vein. So it's a mixture of the VA and the VV Ecmo. VAV, here the drainage cannula is one in the vein and two returning cannula, one in the femoral artery and one is again in the internal jugular vein. It's basically VA Ecmo which is converted to the VAV by adding a venous return cannula additionally. This is being done to improve the oxygenation to coronary and the cerebral circulation in a patient who is already on the VA Ecmo. Like when patient is on the VA Ecmo, develops the North-South syndrome. Again, we'll discuss North-South syndrome later on during my next few slides. Coronary or the coronary hypoxia. VVA Ecmo, here the additional venous cannula is inserted. Hence, there are two venous cannula for the drainage and one single returning cannula in the artery. This is being done when one drainage cannula is not sufficient to get the desired flow. VVVA Ecmo, same as the VAV Ecmo, and VVAV, same as the VAV Ecmo. Advantages are easy to use, used in both the circulatory and the respiratory support, instant hemodynamic stability, no recirculation like the VV Ecmo. Disadvantages: cannulation of the major arteries, like of the pulmonary perfusion, decreases cardiac output due to the higher afterload and the lower preload, and coronary arteries predominantly perfused by the relatively hypoxic LV blood. Known pulsatile flow, risk for the left ventricle distension, risk of the cardiac stunt, pulse pressure less than 15 or 10 mm Hg, possible emboli or the arterial to the arterial side, increased risk for the neurological events. Indications for the VA Ecmo: any patients with reversible cause of the low cardiac output, unresponsive to the conventional measures, VA Ecmo is used to support till the underlying process heals. It can be used in any age group. There are various indications like indicated in the cardiac failure, reversible cardiac failure. It's indicated in all acute reversible refractory cardiac failure, cardiogenic shock secondary to acute myocardial infarction syndrome, viral myocarditis, cardiogenic shock with acute severe mitral regurgitation like with the papillary muscle rupture and the aortic regurgitation, post-cardiotomy, cardiogenic shock, the post-cardiac surgery, failure to wean off from the CPB, and poisoning like beta blocker, calcium channel blocker, etc. Low cardiac output syndrome post-operatively require many times Ecmo. Intractable arrhythmias also are the indication for the Ecmo. Preoperative stabilization in some cases like obstructed TAPVC or TOF with absent pulmonary valve syndrome. Refractory pulmonary hypertension like TGA, abstain malformation. Our own institute experience in the UN Meta is we are electively put the Ecmo in the bigger baby with intact atrial septum and the TGA. And our results are very good in such type of patients, particularly pediatric patients. Our results are up to the national or international. For irreversible cardiac disease, as a breach, patient is for the ventricular assist device, and patient is otherwise waiting for the cardiac transplant. Inclusion criteria: presence of any two criteria observed over 4 to 6 hours After medical resuscitation, like refractory arrhythmias, cardiogenic shock with high inotropic requirement, inotropic score more than 20, lactate level more than 4, rising SVO2 less than 60, rising lactate or SCVO2 like less than 65% with maximum medical management, and all suggestive of the poor tissue perfusion like cold, clammy skin with cyanosis with metabolic acidosis, pH less than 7.1 with oligural less than 0.5 ml per kg per hour urine output despite IFBP and inotropic support preferably before the renal shutdown. Rising lactate 0.75 millimole per hour is also the indications. Exclusion criteria, irreversible disease like malignancy, dilated cardiomyopathy, except for the patient waiting for the final destination therapy or the transplant. Patient on ventilator from more than 10 days, but as Rao sir said, many patients are benefited with more ventilator days, but patient to patient, we have to select and assess the things, whether to put the Ecmo or not. Intracranial bleed, active bleed from the non-compressive site like GI bleed, patient in gross multi-organ failure, severe CNS injury including encephalitis, persistent vegetative state, hypoxic ischemic encephalopathy, intractable seizures, unwitnessed arrest more than 30 minutes. Again is a question not to use the Ecmo in such type of scenario. Uncorrectable congenital heart disease unless is a bridge for the transplant. We can use if patient is waiting for transplant. In neonates, germinal bleed more than grade 3. For pulmonary embolism, inclusion criteria mostly are same except PaO to FiO2 ratio less than 75 or dilated RV with severe pulmonary hypertension. And exclusion criteria are also similar like the heart failure. For sepsis, inclusion criteria, presence of any two criteria following observed over a period of 4 to 6 hours, and peripheral circulatory collapse refractory to volume and the high vasopressures. Lactate less than more than 50 or the 4 millimole or rising titer of the lactate, SCVO2 less than 65%, poor tissue perfusion. Exclusion criteria, irreversible disease like malignancy, dilated cardiomyopathy and COPD, patient on ventilator more than 10 days, age less than 34 weeks, but again most of the centers nowadays using this. In the transplant ICU, indications for donor, Ecmo used in the donor to stabilize the brain dead donor till the organ is retrieved, extracorporeal interval support for the organ retrieval, EISOR. This is done for organ retrieval. The donor is immediately put on the abdominal Ecmo after the cessation of the cardiac activity till the time retrieval team comes, which helps to preserve the abdominal organs. And for the recipient pre-transplant, if patient is not doing well, so stabilization of the patient with Ecmo if patient is waiting. For the transplant, post-transplant, primary graft dysfunction or the graft rejection. For poisoning, indications like calcium channel blocker overdose, beta blocker overdose, cellulose poisoning, aconite poisoning, cardiotoxic poisoning, insect bite, snake bite, or the scorpio bite sometimes require this VV Ecmo. For elective high-risk procedures, high-risk and complex tracheal surgeries, complex tracheal reconstruction, complex bronchial repairs, complex bronchoalveolar lavage, high-risk cardiac procedures like left main stenting, ablation of the refractory ventricular tachycardia, rapid access bedside thermography, or the extracorporeal warming technique for the hypothermic coagulopathy. For extracorporeal cardiopulmonary resuscitation, here patient is put on the Ecmo while giving the cardiopulmonary resuscitation. The conventional CPR fails to resuscitate the patient. It should be restricted to witness cardiac arrest only, as I discussed already, and cannulation should be done within 30 minutes of the arrest. To summarize, consider ECLS when mortality risk more than 50%, like inotropic score more than 20 or lactate level more than 3 millimole, SCVO2 less than 65. Definite ECLS is a mortality risk more than 80% than thought of the Ecmo support, like in the inotropic score more than 30, lactate level more than 4, SVO2 less than 60, intractable arrhythmias with shock, failure to come off cardiopulmonary bypass in OR bed in place with severe respiratory failure, massive pulmonary embolism not responding to the thrombolysis or the impending arrest. Here are the different cannulation already this part is discussed, so will not go further. Central VA ECMO is primarily implemented in the operating room and provide the short-term support in post-cardiotomy patients unable to wean from the CPB. Peripheral VA ECMO can be initiated percutaneously or by surgical cut down outside the OR for the patient refractory cardiogenic shock and the cardiac arrest via femoral artery and femoral or the internal jugular vein access. Another configuration use the standard venous access femoral or the internal jugular with the vein with the arterial return to a graft placed on the subclavian artery. This ensures the cerebral perfusion with the oxygenated blood and allow the possibility for the patients to ambulate while on the Ecmo. Physiology of the Ecmo: blood is drained from the major vein and right atrium and returned to the artery, either femoral or the carotid. Ecmo patients have dual circulation. Net systemic circulation is a mixture of both the Ecmo and the native circulation. Native flow is pulsatile, is by the patient's own ventricle. Forward flow with less or the adequate oxygenation depend on the condition of the lungs. Ecmo flow is non-pulsatile, continuous flow, and retrograde. The flow with high oxygen content naturally. Overall physiological effect will depend on the predominant flow, which flow is predominant, and how patient is recovering. Non-pulsatile flow, Ecmo flow is reflected in pulse contour and pulse pressure. As more blood routed through the Ecmo circuit, systemic arterial pressure cannot become, contour becomes the flatter and intermittent, and they disappear altogether when total bypass is reached. At total bypass, the left ventricle gradually distend and the Thebesian venous return and that ejects when it is full to occasionally pulsatile beat. Usually total bypass not achieved with the extrathoracic cannulation. Only during intrathoracic cannulation will achieve the total bypass. Otherwise, mixture of the both. Most cases, only 60 to 80% of the flow routed through the Ecmo, allowing 20% blood passes through the lungs and heart, results in a diminished yet discernible pulse contour. Pulsatile or non-pulsatile perfusion doesn't differ if adequate blood flow is there, more than 100 ml per kg per minute, and adequate mean arterial pressure exists. Low blood flow, less than 40 ml per kg per minute in the Ecmo, will lead to the inadequate oxygen delivery, shock, anaerobic metabolism starts, and the acidosis and lactate rise. Kidney most sensitive to affect by this non-pulsatile flow and require some diuretics to overcome. Ecmo circulation reduces the preload on the heart as well as blood routed to the Ecmo. At the same time, increases afterload as blood returned back to the artery in retrograde fashion. Reduction in the preload leads to the unloading of the LA and LV, which gives rest to the heart and helps in remodeling of the LV. It also leads to the inadequate forward flow and the hypotension. Retrograde flow from the Ecmo increases afterload, which decreases the LV ejection. This is more when Ecmo flow delivered to aortic arch, like in the carotid cannulation, and directly towards the aortic valve. This leads to the distension of the LV. Increase afterload along with the decreased preload, hypoxic coronary perfusion and electrolyte imbalance will add on, and hypocalcemia and hyperkalemia may be due to multiple blood transfusion. All this can lead to the myocardial stun. Cardiac stun leads to the LV dilate due to the poor contractility and filling of the ventricle by Thebesian and the bronchial vein, and pulmonary edema, mitral valve insufficiency, and increased risk of the pulmonary hemorrhage, left heart stresses, and thrombus. These are many factors can cause the LV stun, and it resolves within 48 hours. Failure to see improvement in the this is a ominous signs and suggestive of the myocarditis or the myocardial infarction. Management of cardiac stunning include the reducing the Ecmo flow, which decreases the afterload and improve the intrinsic cardiac function if LV is good. Giving volume to improve the right heart filling, so we can improve the forward flow of the native heart. Use of the inodilators like dobutamine or milrinone can sometimes help. Intra-aortic balloon pump sometimes required. Balloon atrial septostomy sometimes required, either in the cath lab. And left-sided decompression by LA or the LV vent many times required, and percutaneous transaortic ventricular assist device like Impella device will sometimes help if it's available. Most of the centers still may not have the Impella device available. And it's also costly affair. VA Ecmo increases the RV afterload due to the lung collapse and the pulmonary arterial constriction, which increases the pulmonary vascular resistance and reduces the RV outflow and further decreases the mean arterial pressure. So both the ventricle can fail together. Harlequin or the north-south syndrome and the watershed region. In peripheral VA Ecmo, particularly this thing occur, blood travel in the retrograde from the femoral or the iliac artery back towards the thoracic aorta. So there is an area of watershed, the region with the within the aorta where the two bloodstream meets. It can be anywhere between the aortic root and the diaphragm depending on the output of the LV relative to the Ecmo flow. When antegrade LV output high relative to the retrograde Ecmo flow, area of watershed lies more distal, closer to the diaphragm. And when LV output is low relative to the Ecmo flow, area of the watershed is more proximal and closer to the aorta. Watershed zone is important because oxygenation of the Ecmo flow and the LV output make markedly different. Blood exiting the LV is dependent on the adequate pulmonary gas exchange, which is often impaired in the setting of the acute cardiogenic shock and the pulmonary edema. And so if watershed zone distal to the left subclavian artery, considerable risk of the profound hypoxemia to the brain, heart, and the upper extremity. And in the extreme circumstances, it may lead to the Harlequin syndrome, also known as the north-south syndrome. Here a figure shows the differential saturation in the upper, particularly right upper limb and the lower limb. Poorly oxygenated venous blood ejected by the LV into the ascending aorta to perfuse the upper body and brain. Meanwhile, venous blood passes through the Ecmo circuit, perfuse well-oxygenated blood to the lower body. This led to the differential cyanosis with upper body hypoxia and the lower body hyperoxia, resulting in a Harlequin syndrome-like appearance. Management of this include the treating the pulmonary pathology, increasing the ventilatory support. Rather than giving the rest ventilation, we have to increase the PEEP or the peak inspiratory pressure. Mode of ventilator may be required to change. Aid LV vent when alveolar gas exchange impaired due to the cardiogenic pulmonary edema. In special condition like massive pulmonary embolism with the hyperdynamic LV, decreasing cardiac contractility with the smaller drip may allow for red blood to make it to the arch. And splitting the arterial outflow with a Y connector to deliver the well-oxygenated blood into the venous system and pulmonary circulation will increase the oxygen content delivered by the LV output is called as a VAV Ecmo. So additional cannula should be inserted. Right upper extremity line with serial monitoring of the blood gases is considered standard monitoring for the potential cerebral hypoxia and guide for the need for the VAV Ecmo. Assessment of the pulse pressure at right radial artery helps in locating the watershed region. Narrow pulse pressure indicates the watershed region in the aortic root as Ecmo flow is non-pulsatile, and a wide pulse pressure suggests the watershed zone is in the distal to the innominate artery because of the native flow is more. If returning cannula is in the carotid artery, only coronary gets the hypoxic native flow, while the rest of the organs will get the highly oxygenated Ecmo flow. It gives highly oxygenated flow with the high pressure in the cerebral circulation, which might lead sometimes to the reflex cerebral vasoconstriction. Initiation of the Ecmo, pre-Ecmo checklist, check for the cannula well secured and look for the bleeding at site, check it, all connectors are properly tightened with the tie gun, check all the ports are blocked, connect the flow sensor in the proper direction, calibrate the biotrend and connect the TMC2 cable, note patient's vital before starting Ecmo and pre-Ecmo ABG, electrolytes, VBG, lactate, CBC. Confirm that bolus dose of the heparin is being given. Confirm the availability of the blood and blood product. Blood should be as fresh as possible and at least less than 5 days. Circuit primed properly and de-aired and running with the flow of the 300 ml per minute. Check SCT machine. Request X-ray plate for the radiology and placed under the patient's crash cart with all emergency drugs to be ready. Connect the venous end of the circuit to the venous cannula and connect the arterial end of the circuit to the arterial cannula. Protocol for the initiation are once everything is checked and confirm, go on pump. For centrifugal pump, always first start, nowadays use centrifugal only. So first start the pump and set RPM around 1200, then release the arterial clamp to prevent the backflow. As it is non-occlusive pump, there is always a backflow from the high pressure to the low pressure. And for roller pump, it's the other way around. And first release the arterial clamp and then venous. Roller pump is propulsive pump, so it if any obstruction at the arterial line, it may lead to the rupture of the tubings. Start the pump with the flow rate of 20 ml per kg per minute and gradually increase the flow rate by 5 to 10 minutes by 10 ml per kg per minute up to the desired flow. Adjust the blood flow to gas flow ratio 0.5:1 and start with the FiO2 to 100%. Check for the color of the venous arterial blood. On initiation, immediate bradycardia and hypotension are expected, and from the transient time, initially 1 to 3 minutes, and that usually responds to the fluid challenge. If blood is used in priming, it may require soda bicarb calcium gluconate because sudden loss of the blood causes hypocalcemia and the hyperkalemia, so may require calcium gluconate. Atropine, adrenaline boluses are rarely needed, and if possible should be avoided. If hypotension persists, noradrenaline to be started as an infusion and attach the heater cooler unit to the oxygenator and adjust the temperature around 37 degree. But in case of the ECPR and Ecmo, here we require to reduce the temperature to 35 degree around. Set alarm limits, check for the pre-pump, pre-oxygenator and post-oxygenator pressure, start blood and blood product if required. Once desired flow is achieved, come down to rest ventilator setting. If PCV mode, inspiratory pressure less than 26 millimeter, PIP may require 10 to 12 millimeter Hg, FiO2 30 to 40, IE ratio 1:2. And if volume control ventilation, then 4 ml per kg should be given. Monitor mean arterial pressure and maintain at mean arterial pressure at 70 millimeter Hg for adult and bigger pediatric patient, and neonate it's 40 to 60 is fine mean arterial pressure. Once BP is stabilized, come down on the anatropes and the vasopressors. If blood pressure going high, use the anti-G or the labetalol. Take ABG SCT after 1 hour of starting Igmo. Maintain SCT around 180 to 200 seconds. If heparin coated circuit is available and used, then after 1 or 2 days may not require the heparin. Heparin infusion otherwise to be continued 20 unit per kg, and SCT to be maintained between 180 to 200. SCT more than 200, decrease the heparin and repeat the SCT after 30 minutes. These are practical points. If you want to start the Ecmo, these points will benefit you. Depending on the ABG, Ecmo settings are adjusted. Insert the rectal temperature probe. Post stabilization protocol. Prime card should be restocked and build a new circuit for the emergency use. Plan strategies for the desired blood flow, SCT range, fluid removal, blood and blood product investigation protocols, and all protocols you have to make your own protocols and as per the guideline. Record important times and events, and monitoring protocols like when patients on the Ecmo, 2 circulations exist, native and the Ecmo, so monitoring should include the patient and the Ecmo. Ecmo monitoring include the circuit and the machine monitoring. Patient parameter, clinical and the laboratory. Circulatory monitoring, some patients are Ecmo dependent. Stopping Ecmo for a few seconds can also life threatening. Careful monitoring prevent complications like clotting of the oxygenator or the circuit, block cannula, rupture, air embolism, accidental decannulation. Pressure monitoring, arterial line in both the right and the left hand, preferable. Mean arterial pressure I discussed. Set alarm limits accordingly, and if dampening of the waveform in VA Ecmo when flow increases, pulse pressure decreases. If pulse pressure less than 10, suggestive of the cardiac stunning. And pre-pump pressure normal range ideal minus 20 millimeter Hg up to -70 acceptable in the adult. More negative pressure suggestive of the poor catheter placement, may need the repositioning, inadequate cannula size, smaller size cannula may be there, low volume. If patient is hypovolemic, transfuse the fluid or preferably blood, fresh blood. Pre-oxygenator pressure and the post-membrane pressures depend on the type of the oxygenator and surface area. Silicon membrane oxygenator have higher pressure than the hollow fibers. Blood flow rate, more the flow rate, more the pressure. Increases with the increase in the resistance. Size of the arterial cannula, smaller size, higher will give the higher pressure. Systemic vascular resistance, if high, it will also increases the pressure. More pressure in the VA Ecmo, increase with the kink of the tube. Clogging of the oxygenator, increase the pre-oxygenator pressure. By clogging, these will decrease the post-oxygenator pressure. Set the alarm limit 50 above and below the starting value. Pre-oxygenator pressure always higher than the post-oxygenator pressure. Post-oxygenator pressure kept less than 300 mm Hg to prevent the hemolysis and plasma breakdown. Delta pressure is an important difference between the pre and the post oxygenator pressure. As pre-oxygenator specification, as per the oxygenator specification, this pressure should be acceptable and increase when oxygenator clogging starts. Depend on the amount of the blood flowing through the it, and trend is more important rather than the absolute value for the pressure and the delta pressure. Monitoring of the gases, saturation is not much important. Intermittent probe kept on right and left hand to see the perfusion of the this north-south syndrome. Usually 100% SpO2 will be maintained. More than 90% is fine. SvO2 and the SvO2 for adult more than adult 70% is fine, and neonate 65%. RPM revolution per minute set as per the desired blood flow. Baseline started with the 1200 and gradually increase flow with the same RPM, suggestive of the decreased post-membrane resistance. Either patient is vasodilated or improve in the arterial cannula position, increase preload or increase patient filling or improved venous cannula position. Decreased flow with the same RPM suggestive of increase in the resistance, either vasoconstriction, kinking of the tubing, bed cannula position, hypertension, obstruction in the circuit or at the pump, oxygenator or the cannula, decrease in the preload, hypovolemia, bed cannula positioning, kinking of the tube. Vital parameters, heart rate to be maintained normal 60 to 100, mild tachycardia due to underlying disease, sepsis, poor LV, pain, anxiety, severe tachycardia or the arrhythmias due to the fever, electrolytes imbalance, inadequate blood flow or oxygenation. Temperature to be maintained 97.5 to 98.5. Respiratory rate, rest ventilator setting is already and described. Tachypnea due to the inadequate oxygenation or the sedation or the acidosis. Flow rate, blood flow rate 60 to 150 ml per kg per minute or 2.4 liter per minute per meter square. Started slowly at rate of 20 ml and gradually increased by 10 ml every 5 to 10 minutes. Rapid increase lead to the cardiac stunning. So gradual increase in the flow rate, increase the RPM and gradually increase the flow rate. Blood flow rate decided by oxygen delivery, cardiac output needs SCVO2. Blood flow rate kept the least acceptable, so to provide the sufficient tissue perfusion at the same time avoid the high flow, so there won't be any hemolysis and increase afterload. Gas flow rate set in relation to the blood flow, ratio of the gas flow to the blood flow is 0.5 to 1, maximum 2.5 to 1. Gas flow rate decided by the carbon dioxide level, higher CO2 increase sweep gas flow. Is return cannula is delivering the oxygenated blood. Oxygenation is not much problematic. CO2 is much problematic in such type of the patients. Neurological status, assess the neurology by giving sedation free period every day. Check pupillary reaction and size every 2 hourly. Specifically, neonates are of high risk for the intracranial bleed. Vascular status, assess the peripheral circulation, especially in case of the peripheral VA Ecmo. We have to insert the distal limb perfusion cannula. Nowadays, one below cannula is available. That cannula is having the pores, so that it roughly give 10% of the blood flow to the distal limb. So no need for the separate cannula to be inserted. Every hourly check peripheral perfusion, color of the limb, capillary refill, and the edema. All limbs monitor for ischemic signs due to the thromboembolism. Heater cooler unit, look for the setting. Every hourly check with the circuit light, water flow through the oxygenator. Light should be continuously used, and see the water flow through the oxygenator to prevent the cooling. Also used, and set as per desired blood. Patient temperature normally 37 degree. Urine look, color and output. Dark color of the urine suggestive of the hematuria, hemolysis, and can be the sign of the ischemia. So is an early sign we can see. Laboratory parameter, I said like ACT level 160 to 200 done before initiation, 1 hour after initiation, in 4 hourly, and SOS. Appetitive once a day or as and when required. Maintain 2 times the normal, 60 to 90 seconds. PT with INR once in 3 days, usually not affected by heparin, but it goes high. When it goes high, it suggests to rule out the hepatic dysfunction, DIC, or vitamin K deficiency is important. Hemoglobin maintain 8 to 10 gram. We prefer 30% hematocrit before starting ECMO, after 4 hours, and then twice a day hemoglobin should be checked. Platelets done twice a day. At least I do normal 1.5 to 2.5, but at least we have to maintain more than 75,000 platelet counts. If decreases due to the sequestration in the oxygenator, biopump, or due to the decreased production, infection, drug induced, there are various reasons to, and we have to find out the reason and we have to manage accordingly. Antithrombin 3 level done once in 3 to 5 days when heparin requirement increases. Normal range 120, maintain more than 70%. Anti-factor 10 is sometimes required done, and thromboelastogram if available is fine. Renal function once a day, liver function once in 3 days, ABG with the lactate before starting and 1 hour after ECMO. If unstable, 4 to 6 hourly, otherwise after 2 days, twice in a day is fine. Arterial PO2 usually remains high and non-uniform in VA ECMO. It's not much reliable. Tissue perfusion measured by mixed venous specimen from the pulmonary artery, normally 65 to 75%. Pre-membrane saturation do not represent the true mixed venous, but closer to the mixed venous. So we can use this also for mixed venous oxygenation checking. Echocardiography, daily echo is mandatory to look for the cardiac contractility, cardiac stunning, LV distensibility, and LV thrombosis. We have actually one more lecture for the echocardiography, so will not go much detail. Right hand saturation and daily ECG to be monitored for the hypoxic or the inadequate coronary perfusion, abdominal, head, and chest ultrasound as and when required. Management of the patient on ECMO. Patients require close observation and the proper management. It includes treatment of underlying cause, management of the ECMO and ECMO physiology, prevention and treatment of the ECMO complications. Maintain ECMO flow rate to achieve the SVO2, mean arterial pressure, clinical signs of good perfusion is already discussed, and ventilation management already discussed. Exceptional cases where we need to change the ventilator settings are pulmonary hemorrhage require the higher PIP and the prolonged inspiratory time may be benefited with the APRV mode. Coronary hypoxia and the myocardial stunning require the higher normal ventilator setting. No South syndrome except higher ventilator setting. In such type of cases also, air leak syndrome, low or no PIP and restricted peak pressure less than 20. If tolerating spontaneous breathing is always welcome, or if possible, extubate the patient is the most preferential for such type of air leak cases. Inotropic management, once patient on the VA ECMO, inotrope to be tapered off as early as possible. Mean arterial pressure already said. Inotropes may require if mean arterial pressure less than 60. Higher ECMO flow due to the vasodilatation or with the non-pulsatile flow to improve the cardiac contractility. Fluid management, most patients are fluid overloaded and require the fluid restriction, but sometimes patient can be fluid depleted, like in the capillary leak syndrome, bleeding, diuresis, or sometimes in sepsis also patients require the fluid. If pre-membrane pressure too negative, patient may require the fluid challenge to overcome this problem. Electrolyte balance, hypocalcemia and hyperkalemia common due to the multiple blood transfusion and blood product transfusion and are to be corrected. Antibiotic, prophylactic broad spectrum antibiotics for ventilators and the multiple lines, incidence of the secondary infection 20%, diagnosis of the sepsis based on the regular PCT level and the cultures of the blood, ET and the urine. Patient may not develop fever in the Ecmo. Asepsis guidelines strictly followed to prevent the secondary infection. These are multiple lines and this complicated case. Nutrition to be maintained. Higher caloric state in the Ecmo patient can lead to the higher catabolic state in the Ecmo patient lead to the infection and the mortality. Nutrition supplement essential. Eternal nutrition started as early as possible once Ecmo is stabilized and lactate become normal. Remember, with higher lactate nourishment should not be, eternal nourishment should not be started. It's higher calorie requirement 2500 to 300 kilocalorie for the adult and calorie intake 60 to 90 ml 90 per kg per day. Higher protein 3 gram per kg per day required in these patients because a higher catabolic state. If feed not tolerated, then TPN to be considered, preferably without lipids. Trace elements like magnesium, copper, zinc, etc. are essential elements supplement and these are once in a week. These are to be injected. GI management, prevent the stress ulcer, use the H2 receptor blocker or the proton pump inhibitor with the sucralfate, regular bowel movement with the laxative or the suppository. As far possible, enema should be avoided, can cause the trauma and bleeding. Sedation and muscle relaxant to relieve the sedation for relieve the analgesic required for pain relief, anxiety relief, and the discomfort, and for the amnesia and decrease oxygen consumption and prevent the patient from removing the lines. Promote the synchronous breathing with the ventilators. Most of the sedatives are absorbed by the circuit, hence requirement may be increased. Muscle relaxation is ideally to be avoided if patient is calm. General nursing care as per the ICU protocol, skin care, bowel care, bladder care, eye care, chest physiotherapy and suction. Avoid the trauma while suctioning. There are high chance for the bleeding, and take care of the cannula while nursing care. It should not be dislodged, and while giving the position, it might lead to the increased recirculation or the even flow issue. Complications like vascular complications, cannulation, trauma, bleeding from the cannula site, systemic thromboembolism, air embolism, leg ischemia, cardiac stun, north-south syndrome, etc. can be there. Weaning of Ecmo. Weaning considered when patient shows clinical, biochemical, and the radiological improvement. Now we have to do the echocardiography daily basis. Weaning considered only after giving sufficient rest to the heart. Generally, up to 3 days we should continue once it has been placed. Underlying disease has to be treated and the weaning criteria fulfilled. Again, we have one other lecture for the weaning criteria, so we'll not discuss much about this. Once patient starts maintaining hemodynamics and the respiratory parameters at moderate level of the support, weaning can be planned. Weaning should be done by gradually decreasing the flow from the Ecmo. And decannulation, it's a surgical procedure already described by my previous speakers. In younger children, the vessels are ligated, whereas while in the older children, vessels should be repaired with a patch. All femoral vessels require a surgical repair. My recent pediatric patient currently on the Ecmo, the patient posted for the TGA, and see the sister won the mask and won the gown also, and total aseptic precautions are to be taken. There is a machine showing all the parts, and this is the monitor showing the RPM and the flow. Patient is posted for arterial switch surgery for TGA with intact septum, and patient was bigger, so we could not wean off from the bypass, and Igmo was planned. Now patient is doing well, and see the pulse contour of the systemic radial pressure, and second picture is of the pre and post membrane. It should not be more difference than the 10 to 15. This is the institute where I am working. Is 1251 bedded cardiac hospital, tertiary care center, and we are doing almost all the cases from pediatric to adult, and now we are going to start the transplant within probably 1 month. Thank you.
Any question from audience? In this session, our next speaker is Dr. Mr. Trivedi. He is associate professor at the MIRC, Ahmedabad. He is going to deliver initiation and management of Ecmo. So I welcome Dr. Trivedi to deliver his talk.
नाम बताइए दीदी एक वाले उसको रखिए ये
जल्दी हाँ जी जी
Hello, audible? Yeah. So, good morning everyone, or should I say good afternoon everyone? Okay, good afternoon everyone. Respected dignitaries present at the dais, my colleagues, senior faculties, and all aspirants of Ecmo who are aspirants of learning the Ecmo. Okay. So when you are conducting a CME on a single topic for 2 long days, many of the topics are mainly overlapping. So much of my slides you will already know. So we'll skip through that. We'll just highlight the salient features of the slides. And I hope the glucose from the breakfast is still running into your blood and you will be able to concentrate on my topic and hope to answer a few of the questions from you guys. Okay, so my topic is initiation and management of veno-venous Ecmo. This is my institute, as our madam has already spoken about it. It is 1251 bedded hospital, which is considered to be a largest single super specialty hospital till date in India. We have our Ecmo program since 2015. And we have completed about 130 Ecmos till now with a 60% survival rate. Okay, so that much amount of experience we have. As our institute is cardiac institute, our main Ecmo is VA Ecmo. Our experience is with VA Ecmo. However, we have some experience with VA Ecmo, and of course, we have one survival patient in VA Ecmo in COVID times as well. So I'll be sharing my experience as well. So first of all, we'll see how it progresses from a simple machine to this compact machine as an VV Ecmo. The first case was done on VV Ecmo late back in 1972, where a young 24-year-old male patient who had suffered from a road accident and have a multiple trauma with a aortic rupture. And that time, Dr. Hill has put him on Ecmo and managed to salvage the patient after 72 hours and managed to wean the patient from Ecmo after 3 days. However, the patient did not survive because of multiple sepsis and multiple trauma. After 5 days, he died. But that was the first case, successful case of weaning from VV Ecmo. In that case, he used Bramson's membrane. Later on, as in our line, we always ask for evidence. Okay. We always ask for evidence. If there is no evidence, we are very reluctant to use it. So later on, all the doctors and cardiac professionals have started using Ecmo and try to bring the evidence into the practice. So various RCTs have been performed. The first RCT is performed in 1974 to 1977, which showed statistically no significant survival in case of Ecmo as well as in ventilator groups. Okay, basically we are dealing with, as till now you are all aware that the Ecmo is used in either cardiac failure or both, cardiac failure or respiratory failure. Okay, so what we are witnessing in this lecture is respiratory failure. Okay, so all the talks which I am going to talk is on the respiratory failure only. So statistically significant results are not achieved in that RCT. Later on, all the other centers are doing RCTs. In 1986, the Gatty-Tony trial was come into the picture, which is a single center observational study, which showed that the survival rate is 48.8%, but does not have a comparable group. Another RCT has been performed by Morris in 87 to 91. Still, we don't have any statistical significant survival rate. So till the year 2000, we don't have any conclusive proof of VV Ecmo having a better effect on ARDS management, or say, for example, respiratory failure management. So the major breakthrough trial after 2000, the major breakthrough trial came is CESAR trial. Dr. Harish has told much about it. I'll just like to highlight that after 2000, before from the start of Ecmo since 1972 to 2000, there is also an improvement in ventilator strategy as well. In 1994, the ARDS network has commenced its various trials on ARDS, and they proposed a low tidal volume strategy, high PEEP strategy. Now, before 2000, all the RCTs, the patient was put on ECMO, but they are putting the patient on a very, very high ventilatory supports. Even patient is on ECMO. Okay, so that might be the cause of failure of that RCT as well. So in CESAR trial, what they do is they'll put the patient on VV ECMO and they'll reduce the ventilatory supports, because till 2000, the ARDS network has already proposed a low tidal volume and high wave strategy for ARDS patients. So combining both the strategies, ECMO patients are put on a low tidal volume strategies, and that's how they are managed to achieve a better survival rate. The CESAR trial comprises of 70 centers which across the UK, and it has 180 patients which are randomly allocated into the two groups. And they found that the ECMO patients have a better survival rate of 63% versus 47% in conventional group. They've set the settings which I have mentioned in the slide, that the peak inspiratory pressure should be around 20 to 25, no matter what the tidal volume is going on. Okay, they are not bothered about the tidal volume. They are just keeping the peak inspiratory pressure around 20 to 25, PEEP of 10 to 15, and FIO of 0.3. Later on, the trial published in 2009, completed in 2004. After the publishment, the influenza registry in 2009, which is again a part of ARDS network, which showed again a survival rate of 76% with VV Ecmo. Okay, and currently, just recently in 2018, one more trial has been completed, RCT, that is Eolia trial, and now that trial actually rejected the results of CESAR trial. They were told that the majority of the patient on CESAR trial would not reach to the ECMO center as well. So the randomization is not complete. And in Eolia trial, which is just completed in 2018, they have said that the equivocal response is there with ECMO or conventional mechanical settings in ARDS patients. Okay, so right now we are still in a little bit of controversy. So predominant indication of VV Ecmo is ARDS itself, as we have already seen this slide in Dr. Harish's lecture, that this is a ladder pattern of treatment of ARDS. Okay, first is low tidal volume strategy, then moderate to high PEEP, and then last we will try VV Ecmo. But the most important point in this slide is, for all the strategies to try it out, you have only 7 days. Okay, because there is a relative contraindication of VV Ecmo, that the patient, if it is more than 7 days on ventilator, then there is a relative contraindication for patient to go on VV Ecmo. Okay, so for all these strategies, you have only 6 to 7 days. Indications already mentioned by Dr. Harish. Okay, I won't go into the details, but this is just the guideline purposes. So in a simple term, I would just like to tell you that the potential reversible respiratory failure, okay, if you think that the patient is having potentially reversible respiratory failure, you can put an ECMO, no matter what is the cause. Okay, to elaborate, if you consider the mortality risk is more than 50%, then you might consider to put an ECMO. If the mortality rate is more than 80%, you have to put an ECMO. Okay, this is just a theoretical purpose. But the basic understanding is potentially reversible respiratory failure. Okay. This is the description of Murray score, from which you can get an idea about the mortality risk. Okay, it consists of 4 factors: PA to FI to ratio, chest X-ray findings, PEEP, and compliance. This is again another known as an Apgar score for respiratory system. Again, one of the factors to identify the mortality risk. Contraindication, actually there is no contraindication. Okay, but as I will tell you, the reversibility is the major indication. So irreversibility is the contraindication. So mechanical ventilation at high settings for more than 7 days, that is a contraindication. Just indirectly they are saying that it is an irreversible condition. Major pharmacological immunosuppression, neutrophil count should be more than 1000 at least. Okay. CNS hemorrhage, recent or expanding, non-recoverable comorbidity like cancer or anything else. Age and BMI is still a controversy. Okay, we have already heard about it in the previous lecture as well. Age more than 60 is still a relative contraindication. Okay, these are the parts of the Ecmo pump. It consists of pump, console, oxygenator, and blender. The main problem, how many of you are from cardiac setup? Okay, so you know CPB, cardiopulmonary bypass pump. So the difference between the cardiopulmonary bypass pump and Ecmo is only oxygenator. Okay, the cardiopulmonary bypass pump oxygenator works for only 6 to 8 hours. However, in Ecmo, the oxygenator works for around 21 to 30 days. Okay, so the only difference is oxygenator. Now, cannulation strategy, we have already have a huge lecture about cannulation. I only want to highlight a few points. In VV Ecmo, you have to cannulate 2 veins, okay, and both of them should be a central veins. So we have total 3 sites, SVC and 2 IVCs, 2 femorals basically. Okay, so strategies can be in 3 forms: femoral, one femoral cannula, take the blood into the pump, another femoral cannula, take the blood from the pump into the RA. The second strategy is femoroatrial. Okay, that means femoro IJV. Femoral cannula take the blood into the pump. Again, it will come back to the IJV into the RA. Or other way around, take the blood from IJV and oxygenate into the pump and put blood back into the femoral. And third is single cannula. Personally, I am very fond of using this single cannula. Okay, because it restricts the invasiveness of the cannulation sites, it restricts the infection sites, and plus it provides a very great mobility to the patients. Okay, these all are pictorial definition, pictorial scene of all the strategies. Now we'll first, before managing the patients on VV Ecmo, we'll first look at the principles of VV Ecmo. Why we have put in VV Ecmo? Because patient is in respiratory failure. Okay, so we have to maintain the oxygenation of the patient. So in the initial period, see, whenever you are using a pacemaker, IABP, ventilator, or for that example, an Ecmo, you have to use it to the fullest. Okay, that's why the patient requires that mechanical device. Okay, so in this, when the patient requires VV Ecmo, the patient's lungs are pretty bad. That means you have to assume that the lungs are not participating in gaseous exchange at all. Okay, so in the initial period, lungs do not contribute to gas exchange. Here the very important concept is hypoxia versus hypoxemia. Hypoxia is not well tolerated by the tissues because hypoxia means decreased oxygen supply to the tissues which demands more oxygen. Okay, and hypoxemia means decreased oxygen content of the blood. Say for example, if your patient's saturation is 90 to 95%, but his hemoglobin is 7 gram. On the other hand, you will have a patient whose saturation is 80%, but his hemoglobin is 15. So the 70% or 80% saturation is also acceptable in that patient because it does not lead to hypoxia, even though it has a hypoxemia. Okay. This is one of the important concepts that any venous blood not entering the Ecmo circuit will be shunted through an airless lung. Okay, we have taken the blood from venous system, we oxygenated outside, we'll again pump the blood into the venous system only. Now that venous system blood will go into the left side of the heart via lungs, and lungs are not participating into the gaseous exchange. So the blood which is not coming into the pump as a venous return goes directly into the lungs without getting oxygenated outside. So that will be a shunted blood. Okay, that amount should be restricted. Okay, that should be low. How much it is, we'll see later on. Another important concept is shunt during an Ecmo as well. Okay, so in acute phase, the blood is oxygenated via Ecmo only. The only way to increase saturation is to increase Ecmo flow and decrease the shunt flow. Okay, to increase the circuit FiO2. This is very basic concept of oxygen delivery versus oxygen uptake. Oxygen delivery is cardiac output into oxygen content of the blood. Okay, which is calculated as HB into saturation into 1.34 plus PaO2 into 0.003. VaO2 is again same. Difference between arterial venous saturation and cardiac output into cardiac output. Now the important concept here is in VV Ecmo, the lungs are not participated. Okay, so cardiac output is not the major determinant of oxygen delivery. Oxygen delivery is done outside the body. Okay, so here is instead of cardiac output, we have to take the extracorporeal flow rate, that is ECC, that is liter per minute. So if you want to increase the saturation or oxygen delivery to the patient, you have to increase the flow of Ecmo. Okay, so as the and vice versa as well. If the lung function improves, okay, so lung takes part into the gaseous exchange later on Ecmo. If you put an Ecmo in respiratory failure and later on the lung starts to improving and it starts to take part in gaseous exchange, then the requirement of the flow will decrease, as well as the O2 supplied by the Ecmo is also decreased. Okay, because of decrease in the flow. That we can see in this chart. After till the 30 days on VV Ecmo, the requirement or oxygen delivery from the Ecmo is constant. But after 30 days, as the lung improves, the oxygen delivery or flow is decreased gradually. So that is the first sign of recovery actually. Oxygen delivery during Ecmo is from the two sides. One is lung and another is the membrane oxygenator. From the lung, it depends on cardiac output, alveolar recruitment, lung compliance, ventilator, FiO2, and mean airway pressures. Okay. Initially, when you put an Ecmo, these all factors are zero. Okay. Lungs are not functioning. Lungs are not taking part in gaseous exchange. From membrane oxygenator, it depends on blood flow, shunt fraction, sweep gas flow, sweep FiO2, and oxygenator efficiency. Another big problem in respiratory failure is high CO2. That is very easily tackled in Ecmo. Okay, you have taken the venous blood into the Ecmo circuit, and you can reduce the CO2 by increasing the sweep gas flow. You increase the sweep gas flow, the CO2 will be removed easily. Now, this is one of the important concept of recirculation. As in VA Ecmo, you have north-south syndrome, as our esteemed speaker has spoken much about it. This is one of the problem with VV Ecmo. It is exclusively present in VV Ecmo only. It is not seen in VA Ecmo. What is recirculation? Basically, you say for example, you have cannulated an IJV and femoral vein. Okay, you are taking the blood from femoral vein. You oxygenated that blood into the pump oxygenator, returning it back to the IJV. Now that blood is in RA. And our venous return cannula, femoral cannula, takes blood from venous system. That blood might have chances of again going into the venous return. Okay, so there might be a chance of two parallel circulation occurring. One is a systemic circulation, one is circulation inside the Ecmo circuit as well. Because both the venous return cannula as well as the giving cannula are in the same system. Okay. So this is one of the very dangerous complications because the oxygenated blood will recirculate into the Ecmo circuit only. It will not go into the systemic circulation. The recirculated blood does not contribute to the systemic oxygen delivery, and therefore the efficiency of VV Ecmo is decreased. Whether it requires an intervention, it depends on the degree to which the patient is dependent on ECMO for oxygenation. There is always a recirculation in VV ECMO. Okay, some amount of recirculation is always present in VV ECMO. But whether it requires intervention or not, that depends on the patient's condition. Factors affecting the recirculations are cannula configuration and positionings. You have put a femoral cannula way above in RA and blood from oxygenator goes into the IJV into the RA. So both the cannulas if in RA, then there are high chances of high recirculation. Pump speed, cannula size and flow. If the pump speed is high, that means the pump is draining the blood in very high amount, then also there are chances of high recirculation. Changes in intrathoracic, intra-abdominal and intracardiac pressures. Okay, if you are ventilating the patient with a very high pressures and there are high intrathoracic pressure, that might impair the venous return. Okay, and so the blood from the returning cannula goes into the venous cannula. Direction of ECMO blood flow. This is a very important point while placing a cannula. Okay, if you are placing a cannula, you should know that the returning blood should go into the tricuspid rather than IVC. Okay, so your port of single cannula, 2 lumen cannula should be towards the tricuspid valve, not into the IVC. Percentage of recirculation can be calculated from this equation, that is pre-membrane saturation minus venous saturation upon post-membrane saturation minus venous saturation into 100. Okay, venous saturation can be easily gained by pricking the venous samples, taking a venous sample. Pre and post-membrane sample can be taken from circuit itself. Intervention to reduce the recirculations are increasing the distance between the two cannula so that the blood is not flowing into the circuit only. Alteration in the cannula configuration, use of bicable dual lumen cannula, addition of a drainage cannula, and a manipulation of the reinfusion cannula. Now we'll go back to the management part of the VV ECMO. There are two types of management which we have to do in VV ECMO. One is a circuit-related management and the other is a patient-related management. First, we'll see the circuit-related management. Blood flow. As soon as you start the VV ECMO, the flow should be around 50 to 80 ml per dry kilogram per minute. Okay, you have to start at this flow and see for the saturation. Maximal flow should be started initially, and then according to the saturation you come down on flow, provided you have to accept the saturation around 80 to 85%. Okay, you will not get a full 100% saturation on VV ECMO because there are some kinds of mixing happens, plus there are some blood which is shunted through this circuit. Okay, so maximum acceptable range is 80 to 85%. Calculate the DO to VO2 from the previous equations. Normal DO to VO2 ratio is 5, but we have to accept our goal is to keep it more than 3. Okay, if DO to VO2 ratio is more than 3, we are happy. Oxygenation. In early phase, all the metabolic requirements from ECMO only. Lung is not participating in the oxygenation. SpO2 is usually 80 to 85%. Here comes an important part that you have to train the ICU staff as well. Okay, because you also know that once the staff or any junior doctor sees the saturation of 80-85% on monitor, and they will panic basically. They will call the seniors and do something. But it is normal for these patients. Okay, we are accepting these saturations. So first train the staff to accept to this saturation. That don't panic, it is normal for this patient. Cardiac output and hemoglobin should be maintained because of hypoxia. I have already told you the oxygen carrying capacity should be normalized because we are accepting saturation of 80-85%. The hemoglobin should be high to carry the oxygen. CO2 removal, as I have already told you, it is controlled very easily by sweep gas flow rate. Okay, you increase the sweep gas flow rate, CO2 will be lowered. But the rate at which it lowered should be gentle because if you remove the CO2 very quickly from the circuit, then there will be chance of acid-base disturbances into the body, and that will create a severe cerebral vasoconstriction that may lead to neurologic complication as well. Okay, so rate of CO2 removal should be around 10 to 20 mmHg per hour. Sweep gas flow you can increase up to 15 liters per minute if the CO2 is not removed. Okay. The next most important management part is anticoagulation. Here all the conventional methods of CPB pump should be applied in the ECMO as well. Initially, at the time of cannulation, we are giving a loading dose of 50 to 100 units per kg for anticoagulation to keep an ACT more than 1.5 times to the normal. ACT should be measured hourly and bedside. Okay, hourly measurement of ACT is must, because if the ACT goes down and if the blood clots into the circuit, you have to change the whole circuit at that particular time. Otherwise, patient might succumb. Okay, so ACT should be kept more than 1.5 times normal and it should be repeated every hourly. Infusion of heparin should be started at 10 units per kg per hour with the monitoring of ACT. Okay, ideal rate of heparin infusion should be set according to the monitoring of ACT. Now, for heparin, APTT is actually used for efficiency, but not in these patients because WBC and platelets can also affect clotting. So we preferably use ACT and keep it more than 1.5 times normal. Okay, desired level of concentration of heparin in blood is 0.5 units per ml. TEG can be used bedside. Antithrombin 3 level should be maintained. Okay, if antithrombin 3 is less, then heparin effect might not be visible. So if even after giving lots and lots of heparin, you are not able to achieve the ACT, try to go for antithrombin 3. If the antithrombin 3 level is low, try to supplement it with recombinant antithrombin 3 or FFP. Okay, and then again see for ACT. If ACT is achieved, then there is a problem with antithrombin 3. Try to maintain antithrombin 3 level within 80 to 120% of control. If again you have to consider, as we have given a very high amount of heparin induced HIT syndrome, which is a diagnosis of exclusion. HIT assays are not so specific and never reverse with protamine. Even if patients are bleeding profusely, don't give protamine while they are on the circuit. Okay, because once the circuit is clogged, then you have to change the whole circuit. Heparin substitute can be used in case of heparin allergy or HIT syndrome. And second is platelets. Thrombocytopenia is very disastrous for these patients. It may be because of primary disease, primary pathology of ARDS, sepsis, and exposure to the extracorporeal circuit. If platelets are less than 20,000, then there will be chance of spontaneous bleeding. Our goal is to keep it around above 80,000. Fibrinogen level should be measured and should be kept in normal range within 250 to 300 mg per deciliter. If it is not maintained, then you have to give cryoprecipitates or recombinant fibrinogen. If FDP is high, then antifibrinolytics can be given. Surface coating, as we have already seen in cannulation lecture, that there are various coatings available. We also used normally heparin coated circuits. These are the management of circuit monitors, alarms and safety, as you will see in the workshop as well on the machine itself, that there are various alarms in the circuits. Most common alarm is high pressure alarm into the returning cannula. If there is an obstruction into the returning cannula or if there is a clot in the returning cannula, the pressure might go above 400. The 400 should be the acceptable level. Air in the circuit is strictly avoidable. We should strictly avoid the air in the circuit. Clotting in the circuit, we can see from the flashlight, there are chances of microthrombi or microclot formation into the circuit normally as well. But the clot more than 5 millimeter of size is not acceptable. We should remove the circuit and we have to change the circuit. Electrical power failures can happen sometimes. Now, one of the component of this whole circuit is a water bath. Okay, then now this water bath is actually in the circuit is to maintain the temperature of the blood, of the circulating blood, and we are trying to maintain the temperature around normal in VV ECMO. So this water bath is the main culprit of this uses of this electricity. So if there is a chance that you have put in a patient on ECMO and there is a electricity failure, then you have to first switch off the water bath. Okay, so that your VV ECMO can run on battery for a longer time. Another devastating complication is decannulation. So you have to fix the cannula at two different sites for more securing. Hemolysis can be seen if the inlet pressure is more than 300 millimeter of Hg. And you have to perform emergency drills. As you have started doing an ECMO workshop, and mostly within short time you are putting a patient on ECMO, then before putting up ECMO, just try to do an emergency drills among yourselves, so that at the time of complication you are well prepared. Component and circuit changes if required. If there is a clotting, if there is a leakage, or if there is air in the circuit, then it should be done very fast. Okay, patient is in full support of VV ECMO, it should be done very fast within 1 minute. Then there will be a proper order of changing the circuit. First you have to clamp the circuit, put the patient on full support of ventilator, start the ionodropes, then prepare one already primed circuit, reattach the circuit and start ECMO. This should take only 1 minute. Okay, put patient on maximum ventilator support as you have already clamped the VV ECMO. Traveling can be possible on VV ECMO, as sir has rightly described, that they put patients in distal area, then they airlifted the patient on ECMO to their center. So between the institute also and inside the institute also, traveling can be done with VV ECMO. However, the procedures on the patient should be done in ICU itself. Okay, now we switch our attention to patient-related management. These all are circuit-related management. On patient-related management, the first is we have to maintain the hemodynamics. SpO2 can be used as a guide of hemodynamic management. Remember that we are supporting only and only respiration. There will not be any hemodynamic supports. Okay, as in VV ECMO, we are supporting the heart as well, but in this case, we are not supporting the hemodynamics. Okay, so the ionotropes or any other supports which are running before putting an ECMO should be continued. Okay, however, in VA ECMO, you can switch off the supports once you achieve the mean arterial pressure. In VV ECMO, you should not switch off the supports of hemodynamic. Ionotropes should be continued because there is no direct hemodynamic supports. Echo can be used for guiding the cannula size, cannula position, drainage is adequate or not, and functions of the heart as well. So for example, sometimes you might feel that after putting a VV ECMO, after 1 week or 2 weeks, the heart will go into the failure. So you might switch that patient from VV ECMO to VA ECMO. Okay. Ventilator management is very, very important, as we have already seen in previous randomized control trial till 2000. There is no statistical significant benefit, mostly because of ventilator management. Okay. So ventilator management on VV ECMO is very, very important. While during cannulation, at the time of cannulation, you should give a very, very high FiO2 and ventilator setting. But after cannulation, after starting in VV ECMO, the goal is to use an FiO2 of less than 0.4 with a plateau pressure of less than 25. Okay, this is our goal. When you put a VV ECMO, the blood comes into the contact of this extracorporeal circuit, and there will be high chances of very, very high inflammation, and inflammatory markers will increase. This inflammation will again lead to damage to the lung. Okay, so within first 2 days, you might see that the patient deteriorates for first 1 or 2 days. That this is known as shock lung in VV ECMO. So this is also acceptable, but after 2 days, the lung will try to repair itself. So within first 24 days, you have to provide a moderate to heavy sedation. Okay, because you have just put a VV ECMO, patient does require a full support of ECMO. You have to ventilate with the guideline is pressure control ventilation at 25 to 15. That is 25 inspiratory pressure with 15 of PEEP. IE ratio should be 2:1 for recruitment. Rate is 5 and FiO2 is 50%. Okay, no matter what the tidal volume is going, you just put these settings and leave the lung as on itself. Okay, as the lung improves, this pressure will generate more tidal volume and more gaseous exchange, and so your requirement of extracorporeal flow will be decreased. P-plate target should be less than 25. PEEP can be as high as possible, avoiding the inhibition of venous return. We have seen that the increase in intrathoracic pressure will reduce the venous return and will cause recirculation. If initial PCO2 is high, increase the sweep flow to decrease it at 10 to 20 mm of Hg per hour. After, once the patient is stabilized within 24 to 48 hours, then you try to reduce the sedation and paralysis. Okay, try to reduce the pressors, that is vasopressors, which are going on after the hemodynamics is stable. Give a minimal sedation just to tolerate the VV Ecmo. Okay, and decrease the ventilatory support further. That pressure control ventilation at 20-10, that is 20 inspiratory pressure with 10 of PEEP. IE ratio is still 2:1, rate is 5, plus we have reduced the paralytics and sedation, so there will be some spontaneous breaths with a FiO2 of 0.2 to 0.4. After 48 hours, or after 2 to 3 days, try to awake the patients on ECMO itself. Okay, so our goal is try to mobilize the patient as early as possible on ECMO, or try to make him awake. Okay, it's minimal or no sedation if the patient tolerates VV ECMO well. PCV as above, as we have said already on the lower side, or you can give a trial of CPAP with a pressure support of 20. Tracheostomy should be considered early in the disease, within 3 to 5 days. However, it has a double-edged sword, that the tracheostomy, that is a big surgical procedure, and patient is receiving a very high dose of heparin, so there might be chances of bleeding as well. So risk-benefit ratio should be first check, and then you go for tracheostomy, or if the patient tolerates well, behaves well, then early extubation can be considered. Recruiting trials should be given intermittently to improve the lungs. For recruiting, CLE test should be performed. How you can check that the lungs is improved or not? Recruiting trial should be given until you have find a significant aeration in the X-ray, or tidal volume is increased more than 4 ml per kg with the same pressure support. Okay, so how you can do it is try CLE test. CLE test in which our FiO2 is around 40%. Increase the FiO2 from 40 to 100 and see for the changes in SpO2. SpO2 is around 70 to 80%. If it gradually, suddenly goes up to 100 with increasing FiO2, that means the lung is taking part into the gaseous exchange and lung is start recovering. At that time, you start giving a recruiting trial. Recruitment should be start with CPAP of 25 with spontaneous and pressure support ventilation of 25 to 10. So PEEP is 10, rate is 5, and I ratio is slightly increased to 3:1. Okay, every 10 minutes this trial should be given for hour, 10 minutes per hour. Okay, and as the lung improves, as the SpO2 improves, then you should start decreasing the flow of ECMO, that is decreasing the ECMO support. Airway access is mostly patient is intubated initial days. After, as I have already told you, after 3 to 5 days, try to wean him early. If patient is non-weanable, then try to go for tracheostomy early as well. But tracheostomy should be considered with pros and cons, because bleeding is a very, very high risk complications of ECMO. This will facilitate the mobilization as well as activity. Tracheostomy also, if you do percutaneously or surgeon is doing, then please try to convey to him that they should not make a flap of cartilages or should not extend the incision on the trachea itself. If percutaneous, it's well and good enough. Next management is managing of gas exchange. Arterial blood is the result of mixing the native blood in RA to infusion blood from ECMO. Okay, what we are getting from LV into the artery is basically a blood oxygenated comes from the ECMO into the RA, as well as that blood which is not going into the ECMO as well. Okay, that is shunted blood. So infusion blood into the artery is typically PCO2 is 40, PO2 is 500, saturation is 100, and oxygen content is 22. This is blood which is going into the RA from ECMO. Okay, fully oxygenated from ECMO to RA. Into the RA, it gets mixed with the venous return coming from the system, as well as that blood which is not going into the ECMO. So the saturation drops once it comes into the RA. So that blood contains Ratio of mixing is around 3:1. If you have put a perfect cannula size and location, then the ratio of mixing is around 3:1. So end result of that is PCO2 is around 41, PO2 of 40, saturation is around 80, and content is around 17. That is acceptable. Okay, we have to maintain the hemoglobin around 12 to 15 to maintain the oxygen delivery. Saturation around 80 is acceptable. Once the native lung function improves, it will improve the oxygenation beyond 80. Okay, so maintain hematocrit more than 40 for good oxygen delivery. For sedation, thoroughly sedated during cannulation, because at the time of cannulation, if the patient is not sedated, there might be a chances of air embolism or might be a perforation of artery as well. Okay. Avoid spontaneous breathing because of risk of air embolism because of negative pressure sucks in the air. Rarely necessary to paralyze the patient in VV Ecmo. As early as possible, stop the paralysis, stop the sedation, make him awake. And so if you are using the paralytic agent also, then you have to stop the paralytic agents for 4 to 6 hours in a day, known as a drug day holiday, just to see the neurological status of the patient as well as muscle power and muscle tone of the patient. For adults, you can use the Richmond agitation sedation score and guide your sedation accordingly. Blood volume, fluid balance, and hematocrit is also very important to manage into the VV Ecmo. Goal is to have an adequate hematocrit, normal blood volume, and normal body weight. Blood volume double or triple initially when you attach the Ecmo circuit to the patient. That whole priming volume is actually now the blood volume of the patient. But it does not have any impact on the patient because the circuit is a very, very compliant one. So priming volume, crystalloid, which are mainly used for priming the circuit of Ecmo, is going into the equilibrium into the patient's blood within few minutes of starting an Ecmo. Blood volume should be as high enough to have a CVP of around 5 to 10. Okay. So why this is important? Because we are sucking the blood from the venous system. So if there is not adequate blood volume, then there will be chances of hemolysis because of sucking effect of centrifugal pump. Plus there will be chances of chattering or decreased flow according to the RPM. There will be a decreased flow because of decreased venous return. So you have to maintain the CAP around 5 to 10 throughout the VV Ecmo. Achieving a normal ECF status in first 12 hours is very, very difficult. Okay, because patient has a primary disease itself, patient put on a VV Ecmo, patient has inflammatory changes. So within first 12 hours, it is very difficult to achieve a normal status. But once stabilized, you start to diuresis. You start diuresis to the patient. Patient, if the renal function is good, try to maintain the normal dry weight, which is previously of the patient, try to maintain that. And if the renal function is not good, then straight away go for CVV-HF, that is renal replacement therapy. Temperature very, very adjusted from the water bath, as I have already told you, that water bath is meant for maintenance of temperature. Our goal is to maintain the temperature around 36.5 to 37. However, if a patient has some neurological injury or you suspect some neurological injury to the patient, try to maintain a little bit of hypothermia around the 32 to 34 degrees centigrade for first 24 to 48 hours. Renal and nutritional management. Renal management is same if patient has AKI, patient is not passing urine, patient is fluid overloaded, straight away go for renal replacement therapy or CVV-HF. And for nutritional, as madam has already told in VV Ecmo, it is same for VV Ecmo as well. Normal nutritional support should be maintained throughout VV Ecmo period. Infection and antibiotics. If you have put cannulas and lines in a perfect aseptic precautions, then there will be no documented evidence of prophylactic antibiotic in VV Ecmo. However, if there is a documented infection, you start antibiotic according to that documentation, that culture report. And unlike in line sepsis, where you have a blood culture positive, you straight away go and change the line. Okay, in this patient, you cannot change the line. So unlike in line sepsis or in this patient, if there is a bacteremia, you start giving antibiotics. If patient still not respond, then change the circuit itself. Okay, which is very costly affair. Positioning of the patient is also very important. If patient's hemodynamically is not supported, then put the patient on supine resting position. If patient hemodynamic is fine, then routinely change every 2 hours, change the position. Try to avoid beds or give prone position because this patient is of ARDS. Try to give prone position for 5 to 6 hours a day. This all depends on the primary condition of the patient. Bleeding, again, most devastating complications because patient is on continuous heparin infusion. Once the bleeding is suspected, the simple needle stick injury can cause profuse bleeding and will lead to death as well. Multiple sites can bleed profusely, spontaneously. You maintain all the normal coagulation parameters and try to see for the bleeding sites. If there is a repairable cause, try to repair it and maintain the hemoglobin during the bleeding period. Try to give cryoprecipitates and all the blood processes which are necessary. Procedures from venipuncture to liver transplantation all can be done on Ecmo. Coagulation should be optimized for any procedure. As we have seen, the simple venipuncture can also lead to death. So coagulation status should be optimized before doing any procedure. Extensive use of cautery should be used for hemostasis as well. As I already told you, in tracheostomy, do not try to incise the ring or create a flap while doing a tracheostomy. It will cause a very, very high chances of bleeding. Now, weaning also, there is a sequential step of weaning of Ecmo, but I have just been informed that there will be a lecture on weaning of VV Ecmo tomorrow as well. So I'll skip this slide. The important point of this weaning is when the extracorporeal flow, that is Ecmo flow, if it is less than 30% of required flow, then you start weaning and you start giving a trial off. Trial off is a method of trial out weaning. Okay, sir has already described that weaning is done by decreasing the flow, decreasing the FiO2 and decreasing or stopping the sweep gas flow. Okay, you stop the sweep gas flow, CO2 removal will be stopped from the Ecmo sites. If still the CO2 remains in the normal range, PCO2 is still less than 50, that means the lung is able to wash out the CO2 from the body. So patient is in no requirement of Ecmo. You give this for 24 hours. If still the hemodynamics and arterial gases is maintained, you clamp the cannula, remove the Ecmo. If patient is precarious, means you are thinking that the patient is still little bit on the borderline, you stay the cannula as it is in the body. You just remove the circuit, wait for another 10 to 24 hours, and then if patient is still normal, then remove the cannula. If patient deteriorates, again reattach the circuit. Okay. Decannulation. Okay, after removing the VV Ecmo supports, decannulate the patient. The important point in decannulation, if you have put the cannula by direct cut downs, then remove the cannula with direct cut downs. If you put the cannula percutaneously, then remove the cannula and just press it. Okay. This is one of the very important concept in Ecmo. When you are managing the patient on Ecmo, that is stopping the support for futility. If you have put an Ecmo and patient is not recovering, okay, you have waited for months, but patient is still not recovering, then when to stop? Okay, so this is known as a stopping support for futility. If there is no hope for a healthy survival, brain damage, no heart or lung recovery, and no hope for organ replacement, then you should stop the support. Okay, should explain first to the family. This recovery deadline should be set up front. Okay, because once the patient is on Ecmo, it will go on for months. For cardiac failures, the deadline should be recommended is 3 to 5 days. For lung failures, around 2 to 3 weeks. But as you have seen in COVID cases also, the recovery can come after 30 days, 40 days, 50 days. Okay, so exceptions are always there. We have COVID patients who is recovered after 21 days of Ecmo support. Okay. Another one of the very common contraindication in early days, that is fixed pulmonary hypertension, that is fixed high PVR. that will lead to RV dysfunction is considered to be a contraindication in early days, but nowadays the right heart bypass is also available for such patients. Now, if you are managing a patient on VV Ecmo, there are some disease-specific protocols as well. First is bronchoscopy. If you want to do a bronchoscopy, you first try to achieve a adequate coagulation status of the patient, because once again bronchoscopy can lead to torrential bleeding. Larger air leaks, if the air leaks is more than less than 50% of the lung volume, you should not do anything. You should not put chest tube. If it is more than 50% and hampering cases, put a chest tube with adequate anticoagulation. And if it is major air leaks, then that is one of the major indication of putting a VV Ecmo. Okay, selective CO2 removal, we have already know about it. Pulmonary embolism, ARDS from secondary injury. Now all of these causes should be treated primarily according to the disease itself. If you put the patient on VV Ecmo as well. Okay. Post Ecmo recovery and management. After Ecmo weaning, ventilator weaning should be done according to the institute protocol. Our tendency is to drift into the positive balance, more sedation, increasing the ventilator setting. You have removed the Ecmo, when the patient slightly deteriorate and you change the settings of ventilator. Now that will again damage the lungs. Again patient will deteriorate. So don't try to do that. Accept the lower threshold of saturation and venti settings. Patients who remain on the ventilator with high pressures for a prolonged period of time, they will have an alveolar dead space, which will recover within 1 to 6 weeks. And if the patient's lungs are very bad, the recovery comes after CO2 washout comes late, hypoxia will be recovered very fast. Future aspects of VV Ecmo is still going on in terms of use in vasculitis, autoimmune lung diseases, Koch-Pasteur syndrome, bronchiolitic obliterance. Still, the use is not very clear. It is still in the trial phase. Expected result is same, 58 to 60% survival. Till in last 10 years, 30,000 recorded cases as per the ELSO registry. However, you yourself understand that conducting the prospective trials of VV Ecmo is very, very difficult because of study design, ethics, and interpretation. So till now, total 11 trials already done. We are looking forward to more such trials, and we'll see how. Right now, we are putting Ecmo in a very late stage of ARDS. We'll try to see whether the early putting of VV Ecmo has done some improvement in survival or not. Thank you. Any questions?
Any questions from audience? So thank you, everybody.
Thank you.
Nice talk and
Thank you, sir. I now request Professor Dinesh Kaushal, sir, to kindly present a memento to Professor Jigisha ma'am. I again request sir to present a memento to Dr. Visharal, sir. Now I request Professor Vinit Singh, sir, to kindly felicitate Dr. Dinesh Kaushal, sir. Thank you, sir. For the last session of the day, I would like to invite the next chairperson. The next chairperson, Professor Dinesh Singh, sir.
ये वाला फोल्डर इसमें प्रेजेंटेशन भी है वो सब सारे है छोटा है नहीं खुली आपने पीपीटी का वो सारी वीडियोस है।
इसमें कितनी रखी है हटा दी इसमें वीडियो अलग से रखी है अलग से इसमें है वो
इसमें भी है वो हटाए नहीं
कहाँ पर है मुझे एक दिखा दिया बस
नीचे होने चाहिए चलते जाइए गुड डिलीवरी चाहिए होनी चाहिए तो इसे देख लेनी चाहिए एक से चलो
इस पे है ना हार्ड डिस्क पे फिर लेने काम नहीं कर सकता
ये वाला वीडियो सही पहले स्लाइड शो लगाओ चल गया इसमें
एक मिनट बस
The first speaker for this session is Dr. Abhinaya. He is Director Critical Care and Ecmo Services, Tenos Hospital, Kolkata. He has 20 years of experience in critical care in both India and UK. He is going to deliver his lecture on ECPR and Ecmo transport. The next point.
Thank you, sir. So first of all, good afternoon, everyone. A lot has been discussed about the Ecmo and how VV Ecmo and VA Ecmo. I'm not going to speak any word on the VV or VA Ecmo. I'm just only focused on the next extension of Ecmo we call it eCPR, which is clearly Ecmo plus CPR. Before I proceed further, let me first thank you all of you for still maintaining your patience despite being the lunchtime, and thank you all the organizers for me being here, and Karan who asked me to come here, and all the organizers. When I was in UK learning my Ecmo, the Caesar trial is being mentioned again and again. I was part of Caesar trial at the time. Caesar trial was happening at that time in Glenfield Hospital, Leicester, when I was there. And at the time, roughly done around 200 ECMOs, 200 plus ECMOs. And since we started ECMO at Kainos, we have done around 70 ECMO in the last 3 years. And program is now picking up well. So given all that, now we logically thought that ECP is an extension of ECMO. So in that sense, if I proceed further, my objective of this talk are not too much of going into detail and showering with all the data and all that. It's more about the talking about practicality and sharing experience of a very small center. My center is a very small center. We are only 150 bedded center, not more than a ward of the Kgmu. And further, being in the private sector, we need to talk about the financial and then ethical aspect of it as well as we put all this costly therapy in practice. So, eCPR, again and again, I'm coming to that, we'll explain it a bit more. When the CPR fails, the convention CPR fails, we go on the ECMO plus CPR while doing the CPR, eCPR, the simplest thing you can think about. So, most common indication of that is cardiac. Cardiac is the 80% of the cause of the eCPR, and rest all the causes you can think about. It could be toxicity, it could be pulmonary embolism, it could be surgical, and so many things you can talk about. And there's a long list you can find on the net. There's nothing much I can say about that. At Kainos, our indication for the eCPR mostly is sulfose poisoning. I don't know how common sulfose is in the UP is quite high or not that high here. It's fairly high. I mean, with sulfose, we think that this is nearly non-curable poisoning. It's not. At the moment, our survival rate of oral sulfose poisoning with the help of ECMO has gone to 92%. So sulfose death at Kainos is a rare thing now. We think why sulfose would die. That's the situation that's come. When it started, it was like that, everyone was dying. And now it's changed altogether. One patient we tried on ACS, but that was a 76-year-old doctor's dad, so I was socially pushed rather than more a social reason. Maybe I shouldn't have done that. Trauma was a young guy. I was emotionally good my team. So I just told her, young head, try karo. We tried. That was again a not very good case, but sometimes you have to go with the team and then you don't want to kill the enthusiasm. Family was very keen as well. And we tried one pulmonary embolism as well. Now, whom to put and whom not to put. This is very easy to say that put a Ecmo when it's doing a CPR, but whom to put. There's no clear-cut consensus at the moment. Refractory cardiac arrest is the most common indication, pretty much in all protocols, 84% protocols. And we'll talk about the age. Many people think it's not advisable to more than 65, but still people do up to 70, 80, and what the number, especially in the US. And then we call about the witness cardiac arrest. If it's not witnessed, many people don't like to do it. 56% people put in the protocol. And with more things like no flow, there's no CPR started for 5-10 minutes, don't do it. It's all these criteria, the inclusion problem is still there. People are not clear whom not to do, for whom they should do. But they are very clear for whom they should not do. No reversibility. So when I consider now if I summarize all that in one slide, I would say witnessed in-hospital cardiac arrest is a very good indication for Indian setup. Outside cardiac arrest is something we should avoid because we don't have such a good pre-hospital care where we can rely upon the CPR coavality and then put. We normally don't put an OHCA on that one. If it happens in front of us, we do, otherwise we don't. Upper limit for me is around 65, but some people take 70, some 80 as well. If you ask me, I don't go by strictly by the age. It's more to do with the functionality of a person, how well he is. If at the 65 he is running a marathon, why not? If the 80s put him running a marathon, I would put the patient on Ecmo. So it's more about the functionality and reversibility of the problem. If I think it's reversible, yes, we should do it. No, non-reversible, we should not do it. And the no-flow time, what that means a no-flow time, when this arrest happens and we haven't started the CPR, it was more than 5 minutes. Yes, we were going the very, very bad territory. 10 is even bad. And the low flow, what I mean by low flow, when I say low flow is actually when you do the CPR, you only get 20-25% ejection fraction. Try to limit it to the lower. If we keep going on a conventional CPR, the patient eCPR candidate will start losing the survivable chance. So around 30 minutes. So many people up to 60 minutes, but you should be on an Ecmo in eCPR by 30 minutes if you have a good running program. Shockable versus non-shockable. In our setup, all patients we have died, but non-shockable with them. Only one shockable died so far. So that's a clear, it's a worldwide study as well. People are saying the shockable is has good results, but should we deny all non-shockable? Still, I'm not sure. Many people are denying. And last but not least, how well the CPR is being done. So now, finally, big no reversibility, unwitnessed, no flow, major comorbidity, and that's all we discuss. Is there any evidence? I quickly skipped through that. In this one is a meta-analysis of many studies. We've clearly shown the benefit of eCPR over conventional when there's the indication to do so. And so now one more study where within 22% patient discharged home as compared to 17. I can keep going on numbers, but how common it is. It's becoming more and more common. It's initially 2014, let's go to 2000. This is around 11 times higher. Mortality is only 59%. You need to remember, these are refractory cardiac arrest, and still they were able to resurrect nearly 40% patient. That's like raising the dead. eCPR is actually raising the dead. Again, good survival, but the indicators of bad survival are shorter, good survival are shorter flow time, lower lactates, less organ damage, more the delay, more the mortality. That's what the graph is saying here. In pediatric, results are generally better, but in pediatric, mostly done after congenital heart disease surgery in post-op period and myocarditis as well. At Kainos, we have done not many CPR, but the good thing is we are doing a lot more CPR last year. We're not doing now much because patients are being referred to us early. So they are coming early, and that's why we are putting them early. So we are going to the stage where we need to do the eCPR. That's a good thing happening. In pulmonary embolism, we lost the patient because the family didn't consent for too long. And by the time they consented, it was, I will explain a bit more, then the financial side comes in. So good chances, shockable rhythm, low flow time is less, lactate clearance is quicker, and absence of other organ damage. That's what we have seen. That's a very quick recap of the evidence. Now the practicality. It's very easy to say, okay, there's a patient, let's put on. It's not that easy. How we build the team, that's the biggest problem. And strengthen the system who will support the team, then the financial side of it. If I give you a bit of an idea here, ECP is always the next frontier, as the slide Dr. put it on. Good Ecmo program is a prerequisite. Unless until you have a good going Ecmo program, do not try ECPR, it's not going to work. Even before that, now once that prerequisite done, strong ER team. I always believe the ICU care doesn't start from the ICU, it starts from ER. If your ER is high functioning, your ECMO results, ICU results, everything will be good. Focus before you start thinking ECPR. Put your heart, mind, soul, everything into improving the emergency care of your hospital, wherever you are working. And then strengthening the ICU in general. You cannot have a high-performing ECMO and ECPR program if your ICU mortality is high. First sort out that. First sort out nurse training. First sort out all these things, the basics, infection control. If you have very bad infection control, put on ECMO, patient will die. And then the technology will get the bad name. When I came to Rohtak from UK, the first thing I was asked, "Doctor, patient ventilator mein to marega hi." So that was the thing hit me very hard. Why a patient on ventilator should die? Same thing. Now people are talking to me, "Sir, ECMO le le." बोला भाई तुम्हारी mortality कितनी है ventilator पे? Sir, अभी 60%. Don't take it. So first improve that part, and then once you improve that part, then you go on ECMO and everything else. Otherwise, you will give a bad name to ECMO. That's for sure. So at Kainos, we have sorted that first. We achieved the benchmark in the international standards in whatever ICU we started, and then only move on to the next stage of ECMO and now the ECPR. That's the first thing. You always remember. Outcomes, outcomes, and outcomes, then move forward, not because I want to do it. Not ready, don't do it, prepare first. And ideal team, again, as we all know, but in our team, I have no CTVS surgeon, I have no perfusionist, it's led by the intensive care team, and an excellent OT team, and a nursing team as well. These are my doctors in ICU, who are there 24/7 to do the ECMO. This is my surgeon, he's a general surgeon, who is being trained by one of my friend cardiac surgeon, who was the first one to do ECMO at our stage. Now our general surgeon does the cannulation. It's just for exploring. There's no need to, if you're sitting at a center like Kgmu with the luxury of so many cardiac surgeons, yes, they should take the lead. But in a small town over 3-4 lakh population, where you don't get the luxury of having a CTVS round the clock, what do? You improvise. You get people trained. The effective people get trained and do it. Cardiologist has to be part of team. These are my guys who are working in the OT technicians. Nursing team. The beautiful thing is that none of these girls and boys have ever seen an ECMO before. They all learn there. Everything in-house we learn there. That's my ER team. The longest ECPR, effective, and not only if I ECPR, CPR we have done in our institution is 2 hours, brain intact. If a patient gets ECP at our hospital, most of the time the brain is intact. Big credit to the ER team. Thus again, I'm going to the same point. ER, and ER. So when I started, I was the only one in my hospital who knew the ECMO. But today we are a team of 28 people who the ECMO program is fully independent of me. First 5 ECMO had to sleep in the hospital. Now I don't have to. My surgeon who's seen this over 3-4 times, now does 60 independently and is doing perfect. Again, my OT team can prime the circuit in less than 2 minutes. How did they achieve that? They kept practicing when they are free. When they were free, they kept practicing the old circuit. Now, if it takes more than 2 minutes, it is a failure for us. Why this is so? We cannot afford a circuit running 24/7 for 21 days and discard it. The patient doesn't come. We have to be prudent. And in that way, we have to find the ways. In Western, it is said that you put a circuit on running all the time, being primed and be ready for the use. No, not possible. Train your team well. So intent, commitment, and coordination. That's where we take it. Processes and systems. That's a team thinking, right team. Without a good support, it doesn't work. First of all, you need to learn to identify the patient. You need to have a thing in mind. We need to do ECPR and identify. I've given all the clues which you identify. Second is effective CPR. So if I come into the effective CPR, who is within the team? Here we believe the ICU and ER should be managed by the one person. So if any emergency happen in our hospital, the IC doctor consultant is the first one to see. The response time is less than 10-15 seconds. You did lots and lots of mock drills. You just cannot one day decide you do a mock drill and you just say, I want to do ECP or ECMO. No. We drilled ourselves to the extent we moved our ECMO machine from A point to point B and see how long does it take from where to where. Here we're talking in seconds. If there are 2 doors in the middle and you have to open, you are delaying by 10 seconds. This 10 will become 2 minutes and then lost the patient. There's no point in doing that. And that's why you need a support system and everything to back you up. So we decided to keep our machine in our cath lab. Effective CPR. Less I say, more I say is a bedrock of the thing. I need to play a video. So here now we are coming to the area where effective CPR is very important. So there are 2 ways. Either you do it or let the machine do it. So let the machine do it. This is auto pulse. Some of you might have seen, some might have not seen. This is one of the fantastic device which gives very effective CPR. We tried at our institution. Most likely we'll be buying this. But the biggest impediment to buy this is the cost. It is 24 lakh machine with a 15 lakh consumable, so 15,000 consumable every time. But this is perfect. It can be used in outdoor setting. Yeah, so this next video, please. Move on one more video. This one. Schiller. This one. There's one more machine which can be used. This is more crude machine. You can see this shakes a lot. This cannot be used in cath lab. The CR movement is restricted, so we discarded this machine for us. So most likely the auto pulse is good one, but the good side of this machine is that no consumables and the cost is much less. But for our purpose, it was not effective. Again, I'm coming. It cannot be done overnight. It's a culture. Need to develop the culture of an institution that we put the patient fast, aggressive, and be there to do the things. The video is being played, so I'm going to skip that. Hope I can skip it. Yep. Something gone wrong? Oh yeah. Now with safe cannulation, putting on ECMO. Second standby, I already explained to you at our center, the fastest we have done from door to ECMO is 17 minutes. Longest, the first one was nearly 90 minutes. Patient survived. And average for us is 22 minutes. Many studies from OHCA, out of hospital, average around 57 minutes. So in hospital, somewhere between 25 to 30 minutes is the most standard time in most of the high performing centers. This is the one video I need to play, sorry. Get some help. Listen. This is a video, which is a live video where we are putting an eCPR in a patient. This one, please. Thank you. This video gives you idea what goes in when we do eCPR. Then we divide the people in 6 teams. Just come. It's a bit easy because it's done from our camera. So it will come in a minute. We'll see. There's one team is only for airway. One team is only for the lines. One team is for venous cannulation. One team is for arterial cannulation. One team is for drugs. And one team is only doing eCPR, rotating every minute. And one guy standing behind, only notice on the screen and see what is happening with an overview what is going on so that CPR is not interrupted. Most of the time, these patients, when they come to us, we put line within few seconds, arterial lines, and once we get the arterial line, we know the trace. So most of eCPR, when we do, we have outline to see. So maintain at least mean of somewhere around 60, and diastole of 35 to 40. Try 40, but it's not possible. At least 30 you should try. You see, the one guy is doing the line. I'm doing venous. What's happening there? My wife or TT is on handling a airway. And when we ask someone to stop, say 6 seconds, we are counting 6 seconds because you have to put the guide wire in. You cannot shake at the time, but 6 seconds, stop. Don't get lost yourself. Oh, no, I need to put the guide wire. No, patient. You need to save the patient, not the guide wire. You can go back, stop, or do whatever. Your prime focus in the eCPR should be the patient, not the putting on ECMO. You put a very good ECMO, but see, here I asked the team to stop, but within few seconds, you're not able to do it. Restart, wait. So here I'm stopping my surgeon to stop the procedure, but do not compromise the patient. Take 5 minutes more. but have an intact patient. What's the point of having a very good Ecmo with a bad brain? That doesn't work. Let's move on. It's a long video. This gives you an idea of what goes in when we call the ECPR, the center. Okay, so here I bring the CHEER trial, which is a kind of new trial done in Melbourne. This is a 25 patients, a retrospective study, and they have done ECMO for both in hospital, out of hospital. The survival is pretty decent. They use Lucas in their ambulances, and they do hypothermia. They have a dedicated team. They put patient in ice cold saline as the patient goes on ECMO and then maintain it down. So now coming to the next question of it, who would pay for it? Biggest question. In a government setup, government will pay for it. In private sector, patient will pay for it. And there comes the problem. At our center, we do because we love to do it. 30% of our ECMOs, we make heavy loss. It's not profitable for us. And I must say and must admit, whenever we do ECMO, if there's a mortality, pretty much all, not every all, 60 to 70% time, we face emotional and verbal abuse. You have to have that thick skin in India to work at this kind of a high level of commitment, and the risky procedure with the mortality is extremely high, still made them spend 5 to 6 lakhs on day one, and a total more money around 10 lakhs, and patients still not there, and you take the hell out of a beating on your reputation, your well-being, and a lot of abuse goes around. Then you have to be bold and stand firm and do what you need to do. That's very important to run a program like that. Most of the panels, they don't support, and that's why it's a very difficult territory to charter. Here comes the system support. My brother, who was in the US and who is now in the system, he manages, and one of my colleagues, I don't envy their job. Getting the money out of the patient, 5-6 lakhs on day one, it's not easy. Ethical issues. Again, ECMO is not a therapy. It's not a treatment. It's a bridge. What if a patient has a cardiac failure and persisted? Would you go on a LVAD? Would you go on a transplant? If no, the whole effort has gone down. Should we do it? Should we not? That's a big ethical issue. Bad neurological outcome. What do we do now? We are stuck. Who will pay for the long-term care? You. I have stuck in a situation like that where I paid for the patient all through, and it wiped out my profit for a few patients. So that's life. That's how programs get developed. If you don't develop program, there's a cost to it. Everything has a cost to it. Before I go to mobile ECMO, the shifting to ICU is the next parameter. Shifting to ICU is actually a fantastic thing, which is like a mobile ECMO, but within the hospital. It gives enough experience to take it outside. Let's build the base. You face the problems, and then you proceed further. Can you do some videos, please? So on one time, the lift broke down. So now what I do? I have a ramp in the hospital. So but the managing ramp is a bit steep. We are on the, with the patient, sorry. No. Shifting here. This one, please. If we can play, I don't know how sure we can play. So what you can see that patient, I have to go through that in a second. You can see how high maneuverability you need to shift this patient. Everyone needs to move in tandem. Then it's not focused now. So yeah, message so इसमें next time what we realized, the battery failed. Battery was working fine. Next day it just failed. Now we realize we need a wire. On that day, we realized we need a long wire. That's kind of wire at least 30, 40, 50 meters to go to the stage where you need to disconnect. And we prepared that. And eventually that worked greatly for us when we did our first mobile ECMO. On that day also, that's why we stopped at a dhaba. We anticipated that, and I spotted 5 points on my journey where we are like, I might have to stop and what to do, because I've seen that in my hospital, what I have been 40, 50 meter wire with all these, the shifting within there In India, you need to improvise. You need to think on your feet, anticipate. You need to prepare yourself all the sort of. So that's what I was going to do. That's basically to give you an idea. A lot of moving on. The cannulas are very precariously placed. They can come out in a second. Okay, can go to the presentation. Okay. Again, a journey from ICU to OT for decannulation is also an important journey. These little journeys make a hell lot of a difference, and they teach you to do the mobile ECMO. Do them well. Don't take them lightly. A mobile patient on ECMO is not easy. And that's why we're coming to the next stage. That's why I put shifting before that, because that inspired me to do the mobile ECMO. Safety of patient, lack of safe transport facility, distance from ECMO were the reasons where we started mobile ECMO. Many times every month, there are 2 to 3 patients who die before they come to us, collapse on the way, safe transport not possible. So we thought we will go to the patient. Practical issues, where are you going? Which hospital are you going to? Is it a small, big, what kind? And nowhere we need to put an ECMO is the unknown territory for you. And I cannot emphasize more, anticipate, think ahead. What support you can get, keep them in the loop, prepare them, support them, and response time. The first 2 mobile ECMO, when we went out, we didn't do. We brought the patient without ECMO. But that taught us how to prepare ourselves better. And the third time when we had to go out and did the mobile ECMO, my response time was 15 to 20 minutes. And first was 1 hour. Mock drills, do it, take your chances. Don't do it, come back empty-handed, but you have gained some experience to do it better next time. What can go wrong? You can think anything can go wrong. Patient, equipment, vehicle. When I load my patient, I've done around 200, 300 transfers in the UK when I was there, airline, everything. So when you go, everything loaded. You don't have drugs in the bag. Drugs should be attached to the patient. Fluid should be attached to the patient, ready to move. In ambulance and ECMO, you have 2 people, 3 people. Going wrong, you have no luxury of 20 people supporting you. So prepare everything, attach everything, label everything. Your response time should be seconds, in few seconds, not 30 seconds. Take blood with you. Battery, be ready with a hand crank. For example, whenever we move, we first put a patient on a hand crank. Do it for 4 minutes, 5 minutes, stable patient, then we move. So we rehearse and we play every scenario before we move out. And with the vehicle, ask person to go slow, not fast. Ideally, that's the kind of mobile setup I would have had. That was a picture from my parent institute where I learned the Ecmo, Glenfield Hospital, Leicester. This is the world's largest Ecmo center. But we have this kind of a setup because, no, not practical. Oh, I can get it made, but not practical. This is pretty much safe as well. We haven't had a problem with that. So again, this is a bit of a video, last video, to show what exactly when you go for the mobile ECMO, how you, this one please. This is the last video probably then, last few slides. Thanks for being patient and listening to the post-lunch session. It won't be a few minutes, I promise. So here you see, when you're moving the patient, you maybe take a trolley along with that, and that everything on that trolley, shift the whole trolley, try to minimize your movement. Everything has to be synchronized. Perfect synchrony is the key to a safe mobile ECMO. I can show videos after videos and after videos, but the whole essence of everything what I'm saying is, again, we are moving in. Oh God. Yep, that's a patient in mobile ECMO in the ambulance with 3 people there. Take the patient with you. That's the play picture we took at a dhaba where we stopped the first time. Next time we didn't have the problem. Thankfully, it was sorted. But you may have to do it all that. This one I have to show. This is now take-home message. You can come back to the video. I have to show this. The take-home message from all my talk is very simple. ECMO, eCPR is when everything stops, the ECMO comes in, eCPR comes in. So what do you need to realize? Do not give up. You need to remember when everyone gives up, that's where the role of eCPR comes in. So be patient and be ready to take the eCPR into this time. And always remember that eCPR is the one. This is the this play picture. This is the patient who went on the ECMO. Here you see even And if we, it's not working, no. But at the same time, when you put the NIRS flow after 90 minutes of CPR, because the first case took much longer first. Now it doesn't take that long. Now 17 minutes, I mentioned 17 minutes, we can quickly do it. Never mind, can go back. Just take इसको आगे कर सकते हैं वीडियो थोड़ा आगे इसी को कर सकते हैं तो नहीं इसी को फोन कर सकते हैं. So basically, this is the that's fine. Doesn't slow down. Let me quickly wrap up. So that's still going. Okay, so again, take home message is we're a small 150 bedded center with no cardiosurgery unit. If we can do it, I'm pretty sure Kgmu is much ready and the big centers are ready, but you have to take the lead and train people so this will become more and more common. Teamwork, coordination, commitment. Special thanks to my nurses and admin team. Thank you very much. Any questions? Thanks a lot.
Thank you, Dr. for a nice talk on CPR. Any questions from the audience?
Thank you, sir. I now request Professor Vinit Singh, sir, to kindly present a token of appreciation to Dr. Arvind Daya, sir. Now I request Dr. Vajidi, sir, to kindly present a memento to Professor Vinit Singh, sir.
Dr. Mujahid is head of the Department of Cardiac Anesthesia at Medanta Hospital, Lucknow.
Thank you, sir. This brings us to an end of the academic session for today. I request everybody to proceed for lunch to room 106 on first floor. Thank you.
Left ventricle should right ventricle. The size of the left ventricle should be usually the right ventricle is small. Here we can see some.
कैसे आपको IDCP बाकी बताइए।
So eco is more of a show and tell activity. We need eco for patient selection, for insertion and placement of cannulas, monitor progress of the patient, the hemodynamic progress, detect complication and detect cardiac recovery and weaning. So first of all, patient selection. We need to identify which patients to be excluded and which to be included. There are some reversible pathology and there are some causes like cardiac tamponade, undiagnosed valvular lesions. So if patient is having cardiac tamponade, we have to put a pericardial drain. Patient may not require Ecmo. And if there is some undiagnosed valvular lesion, so we can put the Ecmo for a time period and ultimately we have to send patient for the valvular replacement. And we need to find out any contraindication. If there is an aortic dissection, placing an Ecmo will increase the aortic dissection and the aortic regurgitation because of the increase in the afterload. So, and the AR is also a relative contraindication. So, what is normal? हो रहा था प्ले चलेगा 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 प्ले हो रहा था मेरे में तो प्ले हो रहा था Just a second. Yes. ये जो है 2007 में ही है इसको, इसलिए चल नहीं रहा है इसको। वीडियो पे और नहीं वो 17 वाला कैसे चला गया? उसी में चल रहा था पहले तो। ये 2007 वाला है इसलिए नहीं चल रहा है।
17 वाला आपको पड़ा था।
ये था इसमें 17 में कर दिया था, लेकिन ये तो 2007 ही है ना।
यस मैम,
क्योंकि इसका सिंबल ही वही वाला है। पता नहीं इसको कनेक्ट करने से क्या हुआ, उसमें तो उसी में खुल रहा था। मैं ओपन विद करती हूँ, पता हैंड्स ऑन करो। इसमें तो वही दिखा रहा है 17 अभी। ये 2007 आ रहा है यहाँ, वहाँ पे 17 दिखा रहा है। तो 16 17 में भी चला जाएगा, 16 में भी चल जाएगा, 2007 में नहीं चलेगा, बस इतना है। ये 2006 7 है।
अभी आपके केस में 16 का 16 नहीं है।
ये मैंने अपडेट करवाया भी, अभी चल भी रहा था वो, मैंने घर पे वीडियो चलाया है ना।
इस पे राइट क्लिक नहीं होना।
इस पे हाँ हाँ वो पढ़ाई था भैया, चल रहे थे भैया घर पे, मैंने चलाया, मैंने अभी तो हजरतगंज से अपडेट कराया उसको। ये देखो इसीलिए कराया था अपडेट। ये वाला उसको सिंबल ही अलग है ना। लेट जाओ भैया, पेट हाँ ज्ञान निकाल लो, ऊपर कर लो नहीं तो। हाँ हाँ ठीक है। लेकिन पिक्चर भी नहीं आ रही, कम से कम पिक्चर तो आए। ये तो है ही नहीं सर,
बहुत वायरस
एंटी वायरस पड़ा तो है इसमें, वायरस नहीं, खराबी लैपटॉप का पहले दिन से ही ऐसा है। ऐसे नहीं
मैम बुलाइए, सर बुलाइए, सर आ गए सर।